We continue honoring the life and legacy of Professor Rhoton, master and mentor of many generations of neurosurgeons. And we continue with enthusiasm sharing his teachings across the globe. And the theme of this and topic of this meeting is tradition and innovation, the tradition of learning microsurgical neuroanatomy through lab work, dissection of anatomical specimens, lab training, to then translate into innovations in the operating room, as we've seen along this meeting. Our first weekend was, very successful, exceeding all expectations. We had near 2,000 attendees with 111 countries represented. This means that all continents were represented, and countries that are even remote had the opportunity to join us and learn from masters in neurosurgery. I believe this goes along with Professor Rhoton's leitmotif. He always said he wanted to have an impact in neurosurgery every second, every day. So someone that had been trained under him could taught someone else. So a patient everywhere in every corner in the world could be benefit from these teachings and from this knowledge. And I think he would be proud of what we're all doing today and over the past weekend. Past weekend was very special for many aspects, but I want to highlight what I believe was the most special of all sessions in honor of our master and our hero, Professor Evandro de Oliveira, who actually followed this session and others, and that was something truly remarkable. Tonight, we are starting with this unique session in brainstem and posterior fossa surgery. I'm very honored to have with us Dr. Aaron Cohen-Gadol, who is a pioneer in our field, in the field of microneurosurgical education. He's built a unique resource that is being used all around the globe, the Neurosurgical Atlas, and we'll be so happy to hear from him shortly. And we'll have a special lecture by a genius in skull-based surgery that is being admired admired by many of us, Dr. Atul Goel. He'll talk about petroclival and cavernous meningiomas and how he plans his operations, which will be a fascinating talk. We have, again, in this second weekend of the Rhoton Society meeting, a large presence of the Japanese masters of microneurosurgery. As we were talking, we all deeply admire their commitment to excellence in our field. Oops. I apologize because my presentation just crashed.
While you're bringing that up, I have to say we all have a lot to learn from our Japanese colleagues, Juan Carlos.
Absolutely. Oh, what the heck is going on? I am sorry. So yes, and having the presence of our Japanese colleagues makes this meeting, extremely valuable for all of us. Then we will continue tomorrow morning after our session today with another spectacular session that has been organized by Dr. Morcos and Dr. Rubino, both members of the board who have put together an impressive program. And during, oh my goodness, I can't believe this is happening. I apologize because this is crashing on me. And we'll have the special lecture of Dr. Ali Chris tomorrow.
Do you want to open, close your PowerPoint and reopen it to see if that fixes it? Close the entire program and reopen.
Yeah, that's what I'm doing, but it keeps crashing as I do that. Let's see if I can make it work. It doesn't work. So we will have, I don't need the slides actually, but tomorrow we'll have Ali Chris giving a special lecture on the cavernous sinus, and surgery in the cavernous sinus will be very spectacular. And then we'll have, after that, we'll have Dr. Carolina Martins talking about things that are important in the lab for those that want to have a lab or continue working, and some of the innovations that are happening in microneurosurgical education. Along those lines, we will have Dr. Guillermo Carvajal Rivas, who is a true pioneer on the field of microsurgical education and anatomy. So After that special session on 3D, which we also have Dr. Alice Blasak Rhoton, Professor Rhoton's daughter, will be with us, giving us a perspective on of Professor Rhoton's family life. And after we have a session on endoscopic intranasal skull-based surgery, along with some of our Japanese colleagues too. And without further ado, given that my keynote presentation is crashing continuously, I'm going to pass this along to Dr. Sorenson and Dr. Robertson, who will give us a brief introduction of what the Rhoton collection is, the Rhoton Foundation, and a nice video overviewing Professor Rhoton's life. Please, Jeff, the screen is yours.
I think Jeff would like for me to present first just a few comments about my relationship with Dr. Rhoton over the years. It was a privilege to work with him, primarily during the last 25 years of his career, after his retirement in the mid-1990s. Dr. Rhoton and I participated in a number of skull-based teaching courses in the late 1990s, and that led to the development of a annual resident teaching skull-based course held in Memphis, Tennessee, at our institution at the University of Tennessee. That began in 2002, and the integral part of that was Dr. Rhoton's commitment for every course that we taught to provide the neuroanatomical teaching slides that he did so beautifully in 3D. And that relationship continued from 2002 until a year before his death, when his health failed him and he just could not participate. But he would come each year and participate in that course sponsored by the AANS, and it was a very successful course. One of the issues that throughout all of those courses that I struggled with, and many of the participants, was that after each course of his presentation, with his 3D presentations of neuroanatomy, we would often just sit there in amazement and watch the presentations, but we had no way to preserve his anatomical teachings. And it was in 2010 when Dr. Rhoton presented for the first time a digitized format of 3D presentation that led us to believe that with the digital format that we could, in fact, develop a method whereby we could capture all of his lectures in 3D, digitized in addition to capturing the visual, be able to capture his audio, and thereby preserve his anatomical lectures for future generations. And so with the privilege of working with Dr. Jeff Sorenson at the time, Jeff and I began in 2010 to develop that with Dr. Rhoton. My role in that was, as a past president of the AANS, to secure the funding for the development of the Rhoton collection, which the AANS graciously provided. Dr. Bill Caldwell was part of that at the time. Bill was actually president of the AANS in those years, and that facilitated that development. And then from 2010 until his death in 2016, Jeff and I would go at least 3, sometimes 4 times a year to visit with him in Gainesville to prepare the various presentations in digital format, all of which were provided by Dr. Rhoton and all of his microsurgical dissections and presentations. And he would review each one of them, sign off on each one and say, this is what I want. And then they would be entered into the Rhoton collection. In fact, in February of 2016, roughly a month before his death, we visited with him in Gainesville and did the last preparation of a lecture on the orbital anatomy by Dr. Rhoton for the Rhoton collection. So it was a privilege to have worked with him during this period of time, such an amazing individual, such a gracious individual. And the main thrust of the work that we have, I think, provided is in the development of the Rhoton collection to preserve his teachings in such a way that for future generations, it'll be available for those that have interest in this type of work. Honor Your Mentor Fund through the AANS, and the AANS Honor Your Mentor Fund is part of the NRAF, the Neurosurgery Research Education Foundation, of which I was the chairman of that foundation during that period of time for 5 years. And through that foundation, we established the fund under Dr. Rhoton's name, the Honor Your Mentor Fund for Dr. Rhoton. And those monies to be used for research and for fellowships, specifically in neuroanatomical research activity. So it's a privilege to participate in this, to provide some insight into relationship with a wonderful individual. And certainly it was a wonderful time for me to spend with Dr. Rhoton, and particularly in the last 5 or 6 years of his life that he was to spend with him. He was just a wonderful individual. So thank you for allowing me to participate.
Thank you. And I had the pleasure of Dr. Rhoton through Dr. Robertson's skull-based courses in Memphis, where Dr. Rhoton would come lecture every year. And, you know, his 3D lectures in anatomy just transformed my interest in anatomy. They were so compelling. And I got to know him better, as Dr. Robertson mentioned, through the development of the Rhoton collection. And that's available at rhotoncollection.org. His images are interactive. The videos are in 3D or 2D formats, and there'll be another lecture about that tomorrow to demonstrate that. So again, I was impressed with Dr. Rhoton's ability to have really high expectations for people that worked around him, his fellows, everyone that he touched, but he motivated people through kindness and encouragement, and led them to go on and do great things. So, and the laboratory that he had was really at the crossroads of art and science. And he realized how the impact of this little laboratory could spread throughout the world exponentially with each new person that he mentored. And as you mentioned that earlier, his goal was that the work in that laboratory would help a patient somewhere in the world every second of every day. And I think he did accomplish that. And I think the Rhoton Society will continue to multiply the impact of his work as he instructed us to do. He instructed us to keep working, which we're going to do. But now I'd like to play a short video that Dr. Robertson and I put together after Dr. Rhoton left us in 2016.
The brain is really, truly the crown jewel of creation and evolution. It's our greatest unexplored scientific frontier. Some people say it's the seat of the soul. I don't know that it's the seat of the soul, but certainly through our brain and mind, we become aware of our own essence and our own soul.
Al Rhoton was born into the most humble of circumstances and taught to work hard every day. He was drawn to a life of service and considered social work in the seminary. But his first exposure to neuroscience in college sparked his true passion, which when combined with his curiosity, work ethic, and love for humanity, resulted in a lifelong quest to improve neurosurgical care through research, teaching, and mentorship.
The great surgeon is like the giant oak tree that sends its roots deep into the earth to the source of love and kindness, from which we constantly replenish our ability to treat our patients with compassion, and it makes us reach out with our limbs and branches to assist the world with skill and knowledge.
His laboratory was the best in the world, producing science that was also great art.
Our goal in this is to make all of them Michelangelos of microsurgical anatomy. The best image guidance that you can have is the knowledge of microsurgical anatomy. And I started this to make what is a delicate, faithful, awesome experience for my patients accurate, gentle, and safe.
His body of work is on par with any of the great anatomists of the past. He gave himself, his time, and his work freely to us. He showed us the impact one teacher can have on the world. He offered us true friendship over a free cup of coffee. We will miss him dearly.
There is no finish line.
Thank you, Dr. Rhoton.
It's always so special to hear that voice, isn't it?
Great.
Thanks, Dr. Rhoton.
Thanks, Jeff and John. Do you guys have anything else?
Nope.
Good.
Go ahead.
Thank you so much. We're looking forward to hearing more from you later. I think next we're going to have Dr. Kobayashi, who is the president of the Rhoton Society, give us a few remarks. Please, Sige, unmute yourself and share with us your thoughts. Sige, Dr. Kobayashi, you are muted.
You hear me now?
Very well.
Yeah. Thank you, Joanne. On behalf of all members of the board of the Rhoton Society, I'd like to say thank you to everybody, especially, first of all, I'd like to say, Joanne, you have made a fantastic program, this meeting. And I'd like to congratulate you on this. Secondly, I'd like to say thank you for attending this meeting, all our colleagues neurosurgeons from all over the world. We have done about one half of this meeting and hope that you will enjoy the second half of this meeting and program. Thank you very much.
Thank you, Professor Kobayashi. Dr. Matsushima, please give us a few words.
Okay.
In our last board meeting, Dr. Matsushima was elected by unanimity the next president because Dr. Kobayashi asked he said he wanted to retire and spend time in a different way, which we all understood very well. And we are honored to have Dr. Matsushima leading the society now. So please, Toshio.
Yeah, thank you, John. I am Toshio Matsushima, newly appointed president of the Rhoton Society in next 2 years. I feel very honored, and at the same time, I feel a strong responsibility as a president. I'll do my best to spread the knowledge of the microsurgical anatomy to the world and work hard so that our patient will receive the more accurate, gentle, and safe operation as Dr. Rhoton hoped. Actually, first, I'll work together with Dr. Ture of Turkey so that the third Rhoton Society meeting in 2022 will be a success. I appreciate your understanding and support. Thank you very much.
Thank you very much, Dr. Matsushima. As you just heard, we also elected Dr. Ture to run the third Rhoton Society meeting in 2 years in Istanbul. Hopefully we can travel at that time. And it is such an honor to have a giant in neurosurgery as he is giving his efforts for the next meeting of the society. So with no more details, let's move on to our first session of the day, which is on brainstem and posterior fossa surgery. We have a spectacular panelist, and our first speaker is going to be Dr. Matsushima, but this is Dr. Matsushima Jr., Ken Matsushima, who was also a fellow with Professor Rhoton. I am not sure if Professor Matsushima Sr. want to say any words about it, or we should just jump directly into the talk. Ken, are you ready?
Yeah, I'm ready.
Very good. Good to see you.
Thank you. Let me share my slides. First, I want to say thank you to Professor Kobayashi and Professor Fernandez Miranda for giving me such a wonderful opportunity. I studied microsurgical anatomy under Professor Rhoton in 2013 to 14, and after coming back to Tokyo, I am now working under Professor Kono in a member of the skull-based team. When Professor Rhoton talked about the posterior fossa anatomy, he always started his talk with this rule of 3. When we look back the earlier time of the lab at University of Florida around 1980, we can see he wrote these articles based on this rule of 3. All these All these important anatomical structures in the posterior fossa can be divided into these three complexes. And this rule can greatly help young neurosurgeons to understand posterior fossa anatomy. This rule can also help understanding of anatomy and surgery for vascular decompression syndrome, but this topic will be talked in the next lecture. The brainstem is composed of three parts: midbrain, pons, and medulla, and the cerebellum has three surfaces: tentorial, petrosal, and suboccipital surfaces. Between these three brainstems and three cerebral surfaces, three cerebral brainstem fissures, the biggest fissures in the posterior fossa, are located. The cerebral mesenteric fissure is between the midbrain and tentorial surface. The cerebral pontine fissure between the pons and the petrosal surface, and the cerebral medullary fissure between the medulla and the suboccipital surface. When you look into the fiber connection between the cerebellum and the brainstem, the cerebellum is connected with the brainstem by the three cerebral peduncles: superior, middle, and inferior cerebral peduncles. You can find superior peduncle in the cerebral mesenteric fissure, middle peduncle in the cerebral pontine fissure, and the inferior peduncle in the cerebral medullary fissure. About the cerebral arteries, the STA runs around the midbrain, while passing beside third, fourth, and fifth cranial nerves, and crosses in the cerebral mesenteric fissure to reach the tentorial surface. The ICA runs around the pons, passes beside the sixth, and makes the meatal loop around 7 and 8, and crosses along the cerebral pontine fissure to reach the petrosal surface. Rarely, the ICA embedded in the jugular or bone around the subarcuate fossa, through which the subarcuate artery enters the bone. If the ICA embedded only in the jugular, you only need to dissect the jugular. But when the ICA embedded deep in the bone, you need bone drilling. In this acoustic tumor surgery, in a park bench position, in the retrosigmoid approach, the ICA embedded in the jugular to block the surgical trajectory. So we dissected the petrous jugular around the embedded point, and cut the subarcuate artery to mobilize the ICA and expose the tumor. After opening the acoustic meatus, we localized the facial nerve by neuromonitoring and dissected the tumor from the facial nerve to achieve complete resection. After finishing tumor resection, you can see mobilized the ICA and preserve the facial nerve. In another case with the acoustic tumor, the ICA embedded not only in the jugular, but also into the bone. So we drilled the bone around the ICA and dissected the ICA to mobilize it, to expose the tumor. The pica runs around medulla, passes between the lower cranial nerves, and gets into the cerebral medullary fissure to reach the suboccipital surface. In some cases, the pica bifurcates from the vertebral artery extracranially. The OA pica bypass is usually performed in the caudal loop of P3 segment. But if the caudal loop is inconvenient as a recipient, you can use other segments as an alternative recipient. The posterior fossa veins are also composed of the three lobes: galenic, petrosal, and tentorial lobes. The superior petrosal vein, the biggest vein in the cerebral pontine angle, is a major branch of the petrosal loop, but it also has connection to the galenic and tentorial loop in usual. As like the Sylvian fissure in the supratentorial surgery, fissures are the biggest gateway for neurosurgeons to access deeply treated lesions without dividing any neural structures. In the infratentorial surgery, the biggest fissures are the three cerebral brainstem fissures. The cerebral mesencephalic fissure extends caudally between the midbrain and the cerebellum and opens cranially into the quadrigeminal cistern. During variations of the supracerebellar infratentorial approach or occipital transtentorial approach, opening this fissure helps to minimize the need for cerebral retractions and reducing the tension on surrounding vascular structures. When you open the entire fissure and divide the superior medullary velum, you can access it to the upper fourth ventricle. The superior and the inferior limb of the cerebropontine fissure and the petrosal and postscribal fissures meet at the supraflocular cistern, an optimal site to open the arachnoid to drain the CSF and identify the vein of the cerebropontine fissure, the major branch of petrosal vein. In the retrosigmoid approach, opening the arachnoid along the superior limb of the cerebropontine fissure provides wide access to the middle cerebral peduncle and the trigeminal nerve. And opening the inferior limb of the cerebropontine fissure allows the elevation of the flocculus and the choroid plexus to expose the root exit zone of the facial nerve, the posterior surface of the inferior cerebral peduncle, and the pontomedullary sulcus deep to the nerves. For such cavernoma at pontomedullary junction, we have preferred to use the perifacial zone through the pontomedullary junction via the infraflocular approach. In a sitting position, you can see lower 7 and 8 and 5th cranial nerve, superior petrosal vein, and dissected the flocculus and the choroid plexus to elevate them and coagulate the choroid plexus to shrink it. And after localizing the facial nerve, in this case, between the root roots of 10th and 11th cranial nerves, we found the vein of pontomedullary junction, this tiny vein along the pontomedullary sulcus. And we entered into the pons and found the cavernoma and resected in a piecemeal fashion to achieve complete resection. Since the tonsil is attached only at superlateral margin as tonsillar peduncle, the cerebromedullary fissure is the biggest fissure in the posterior fossa. We classified this wide space as medullotonsillar space, uvulotonsillar space, and the supratonsillar space. The vein of the inferior cerebral peduncle coursing out along the tenure is a good landmark to incise the talar along the tenure when opening the fourth ventricle. The vein of the cerebromedullary fissure coursing near the talovelar junction is a good landmark for determining how far the fissure has been opened when a large tumor occupied this space. This is another cavernoma case in a prone position. We lifted up the tonsil and cut the talar along the tenure to get the widest space out in the fourth ventricle. And here is the lateral recess. After localizing the facial nucleus, we reached the hematoma and the cavernoma and then resected. Intradural drilling of the temporal bone facing the cerebropontine angle is another technique to extend the surgical field in the cerebropontine angle. But vital structures inside the temporal bone, such as semicircular canals and an internal carotid artery, should be preserved during the drilling. Based on the rule of 3, you can find the suprameatal extension in upper complex transmeatal extension in middle complex, and the suprajugular extension in the lower complex. The suprameatal extension by removing the suprameatal tubercle enables access the Meckel's cave and the posterior regions. The transmeatal extension, removing the posterior wall of the internal acoustic meatus, provides reach inside the acoustic meatus. You can see each of the four nerves with the nervus intermedius, and here is the transverse crest. By the suprajugular extension, during this roof of the jugular foramen, you can access the upper jugular foramen from the cerebral point and angle. This was my first project with Professor Rhoton, and he taught me how to do the research work from the basics. This is a meningioma extending into the upper jugular foramen and acoustic meatus. In a park bench position, we dissected the 7 and 8 cranial nerve from cranial side and lower from the caudal side, and dissected the dura around the acoustic meatus and jugular foramen, and drilled the temporal bone to open the acoustic meatus and jugular foramen. After resecting the intrameatal tumor, we opened the jugular foramen and dissected the intrajugular tumor. Now you can see the gross pharyngeal nerve inside the jugular foramen. Thank you. Thank you very much for your attention.
That was a wonderful presentation, Ken, as always. Very much appreciated. Beautiful exposition of anatomy and how to apply that into surgery. Really nice.
Thank you very much, Yuan.
So Professor Matsushima Senior, I believe it's your turn. So please go ahead and share your screen.
Okay. Can you see the slide?
Yep.
Okay. Hi, everybody. I am going to talk about the surgical anatomy and the procedure for the microvascular decompression surgery. Professor Rhoton proposed the rule of 3 in the CP angle, which helps us understanding the vascular compression syndrome. The slide shows the left CP angle. The 3 cranial nerves are compressed by the 3 cerebellar arteries at different levels. Then trigeminal neuralgia, hemifacial spasm, and gross pharyngeal neuralgia develop. 3 different areas in the CP angle should be approached through 3 different directions. The center illustrations were drawn by Dr. Hitotsu Matsu. The figure at the right upper corner indicates 3 different craniotomies on the left side. First, trigeminal neuralgia. Trigeminal neuralgia can be caused by compression at any systemic portions of the nerve. The most common offending artery is the SCA. In some cases, however, venous compression or arachnoiditis cause the disease. It is important to recognize the anatomical relationship between the trigeminal nerve and the SCA and ICA. We utilize a combined trans-horizontal supracerebral approach for trigeminal neuralgia. A craniotomy is done at the junction of the transverse and the sigmoid sinuses. In the approach, 2 cerebellar surfaces, the tentorial and pectoral surfaces, are being exposed and a wide subdural space is obtained on the tentorial surface. It provides the appropriate surgical field in which the SCA is shifted medially. The approach to the trigeminal nerve is not easy. It is because the region is deep and the petrous vein are obstacle. On the slide, we can see the tributary of the petrous veins, especially the vein of cerebropontine fissure. We neurosurgeons should know the anatomy of the petrous vein in detail. It is because some serious complications occur after sacrificing the veins. Cerebral retraction sometimes pull out the draining point of the vein. The draining terminal portion of the vein is not covered by the arachnoid membrane. We have to be careful with the cerebral retraction and first have to dissect the arachnoid membrane around the vein to make them free. I'll explain the tentorial stick string retraction technique, since I sometimes employ the technique. This method is carried out by placing one stitch in the tentorium, passing and encircling the suture around the SCA, and then anchoring the artery by a sling of the suture. This technique allows the complete transposition of the offending SCA. I'll show you the approach and tentorial stick string retraction technique using the video. The offending artery is the SCA, left side. The corner of the transverse and sigmoid sinus is exposed. We can see the petrosal surface, and I follow the horizontal fissure to reach the suprafloccular cistern. Now I cut the arachnoid membrane over the suprafloccular cistern. We can see the 7th and 8th nervous complex. Now I make the free the petrous vein from the arachnoid membrane. I can see the 4th cranial nerve, and still I'm cutting the inside. Now I can see the bridging vein to the tentorial surface. We can obtain the wide operative field. SCA is compress the trigeminal nerve. So I'll move the SCA, offending SCA medially. I'm going to use the stitch string retraction technique. I put the one stitch on the tentorium and make the sling of the suture for fixation of the offending SCA. In the next case, the offending artery is a large tortuous vertebral artery with a strong arteriosclerosis. I'll show you the video. This case is an old one. I operated on the patient 25 years ago. Left side. A large tortuous VA compressed the trigeminal nerve. At this time, I inside the petrous vein to abrade the. I'm checking the moving of the VA. And I use the stitch string retraction technique. But at that time, I used the very large needle when I started the MVD. I'll make the sling for decompression. Now, trigeminal nerve is decompressed. I also decompress the SCA, which compresses the nerve from medial side. Next is a hemifacial spasm. The left half of the slide demonstrates the anterior view of the left CP angle. The lateral portion of the pontomedullary sulcus is a concave, called supraolivary fossette. It is indicated by the yellow arrow. The facial nerve is situated medial to the acoustic nerve, and the exit zone of the facial nerve is present in the supraolivary fossette. There, the arteries such as the AICA, PICA, and VA often change their courses. It has generally been believed that arterial compression at the exit zone of the facial nerve can cause the spasm. The fructus is an obstacle in exposing the exit zone of the facial nerve. Therefore, we have to approach it between the fructus and ninth cranial nerve, which I call the infrafructal approach. The right half shows the histological specimen of the cutting face of the pons at the level of the exit zone. We can see the change from the facial nerve wrapped by the central myelin to that wrapped by the peripheral myelin at the exit zone. The AICA gives a rise of the perforating artery at the facial nerve exit zone. Right illustration demonstrates the perforating arteries during the compressing procedure. When we place a few pieces of the prosthesis under the compressing artery, we had better insert them from above to below. The illustration shows infrafructal approach on the left side. To expose the exit zone of the facial nerve, we have to approach between the fructus and ninth cranial nerve. The anatomical landmark is a choroid plexus protruding from the foramen of Ruschka. It is situated just in front of the origin of the ninth cranial nerve. After separating the arachnoid membrane and the rhomboid rib from the 9th and 10th cranial nerve, we retract the fructus superiorly. Then we can see the exit zone. The direction of the retraction of the fructus is very important. The illustrations show different intraoperative views depending on the offending arteries. The AICA divided into the rostral and caudal trunk, and in the illustration, the rostral trunk contact with the facial nerve. The loop of the offending PICA is often hidden by the 9th and 10th cranial nerve. I'm going to show you the MVD for the hemifacial spasm. The region is on the left side. Offending artery has a large VA indirectly, and the PICA directly. The PICA directly compressing artery will decompress after decompressing the VA. Left side. Now I can see the large VA below the 10th cranial nerve. I'll open the lateral portion of the cerebromedullary fissure to expose the origin of the 9th and 10th cranial nerve. Now we can see the facial nerve and ICA and VA and PICA in the supraolivary fossette. I am checking the movement of the tortuous VA. Then I'm going to use the stick swing retraction technique for the moving the VA. I retract. Then after that, I'll place the piece of the Teflon felt under the pica. Pica direct compress the exit zone. The third one is the glossopharyngeal neuralgia. The pica with upward loop is often offending artery. I noticed the three features of the offending pica in the case of the glossopharyngeal neuralgia. They are first originating at a high level. Second, making an upward loop. And third, causing in the supraolivary fossette. We can see these three features on the MRI and MRA. I'll show you the MVD procedure through the transcondylar fossa approach. The region is on the left side. When I started, I used the prone position. Now I retract the cerebral hemisphere. Then we can see the easily to 9 and 10th lower cranial nerve. In this case, pica upward loop push the 9th and 10th cranial nerve. It's located between the 9 and 10th cranial nerve. So through the approach, the loop of the pica can be pulled out easily for decompression. Very easy. I fix the loop of the pica to the dura mater on the jugular tubercle. Now you can see the 9th cranial nerve, which was decompressed. I wrote on the MVD in my textbook on surgical anatomy and surgery on the posterior fossa. So please take a look at the textbook if you would like to study furthermore. Dr. Rhoton told us the combination of the knowledge of the microsurgical anatomy and the use of the operating microscope has improved the technical performance of many neurosurgical procedures. Thank you for your attention.
Thank you, Professor Matsushima. Phenomenal lecture, great expertise.
Thank you
for sharing. While we prepare for our next speaker, Dr. Kono, who Dr. Matsushima will introduce, we have a question from the audience about, and I open this to Dr. Matsushima and everybody else who want to respond. Is there any, I believe this is coming from, anyway, the question is anybody, what do you think about Peter Janetta's theory on essential hypertension and diabetes being microvascular compressive disease?
Yeah, I tried several cases. It's effective, but you know, we have a drug. So it is difficult to explain the patient to treat the hypertension, to open the craniotome, you know. So when we have a patient with hemifacial spasm and also hypertension, we can try both.
Okay.
But only hypertension, we don't try.
I understand. So there can be some connection there. Very interesting. Very good. So, Dr. Matsushima, please go ahead and introduce Dr. Kono.
Okay. Next moderator, next speaker is Dr. Kono. Dr. Kono is Tokyo Medical School chairman, and he is one of the leaders in the skull-base surgery. He is specialist, particularly the acoustic meatus, melanoma. Please, Dr. Kono.
Can you hear me?
Yeah.
Yes.
Okay. So it's my great honor to be here, and I'll talk about the CP angle tumor surgery. So could you start my PowerPoint I sent with mute mode? I'll talk by myself. Start my PowerPoint, please.
Laura, are you starting the PowerPoint? There you go. Thank you.
Slideshow, please. So Okay, hello everyone. I'm Professor Kono from Tokyo, Japan. I'll talk about the surgery for vestibular schwannomas and the other CP tumors. About COI, there's nothing to declare. Before starting my presentation, I'd like to introduce myself and our institute shortly. I'm a chairman of Department of Neurosurgery of Tokyo Medical University Hospital. I'm a skull-based surgeon, and I used to be a disciple of Professor Keiji Sano and Professor Tomio Sasaki. And I'm a once active member and a WFS educational course faculty member. At our skull-based center of Tokyo Medical University Hospital, we perform surgery for CP tumors, 2 or 4 cases per week, totaling about 150 cases per year. My personal experience of surgery for CP tumor is more than 2,000, including 1,400 vestibular schwannomas. As you know, there are various surgical approaches for CP tumors, and I have been selecting these approaches for more than 25 years. For vestibular schwannomas, I used lateral sigmoid approach in most cases, in contrast with the other CP tumors, selecting lateral sigmoid, transmastoid, middle cranial fossa, and trans or paracondylar approaches like this. Mastoidectomy procedure was used in 240 cases for these diseases: meningioma, epidermal cysts, facial nerve schwannomas. Middle cranial fossa approaches was used in 240 cases for these diseases. Combined transpetrosal approach was used in more than 100 cases for these diseases. I talk about the vestibular schwannoma surgery, CP angle skull-based meningioma surgery, and surgery for jugular foramen tumors. And lastly, I'll talk about the mastoidectomy, our method. Now we are going into the vestibular schwannoma surgery. In our series, CUS 4 with brainstem deformity or over midline cases accounts for more than 1,000. So most of our patients had large tumors. These are small tumors in young patients for hearing preservation surgery. I think surgical policy is very important. And basically, we are aiming at total removal in every case, but some tumor resection leaving a tiny fragment on the nerve, facial nerve to avoid persistent facial nerve palsy is acceptable. But intermeatal part of the tumor is totally removed to prevent recurrence. We routinely use the intraoperative continuous facial nerve monitoring with direct electrical stimulation of root zone of the facial nerve to avoid facial nerve palsy. So our policy is no recurrence and no facial nerve palsy. In this case, I left the tumor around here, 98% resection without any facial nerve palsy. In this case, I left the tumor around here, but we can't see the remnant on the MRI, 99% resection without any facial nerve palsy. We can't see the remnant, 99% resection without any facial nerve palsy. The key points in vestibular schwannoma surgery, I think, are the continuous facial nerve monitoring, wide and deep opening of the posterior wall of the internal auditory canal, 7 gates and 3 dissection planes in tumor removal, stabbing, and lifting of the tumor from the CPM system. About the intraoperative monitorings, we use 3 types of facial monitoring: free-running spontaneous EMG, occasional direct electrical stimulation, and continuous direct electrical stimulation. For hearing monitoring, we use ABR and CNAP, and other monitorings like these. About the intraoperative facial monitoring, we use the electrified microsurgical dissectors for occasional direct stimulation as well as NIM system. And this continuous direct stimulation with 1 Hz is actually a real-time monitoring during tumor dissection. We reported this method 9 years ago in Acta Neurosurgical. After identification of the rootic zone of the facial nerve, I placed an electrode for continuous facial nerve monitoring. This is the control before tumor dissection. Sudden decrease in all facial muscle responses occurred during tumor dissection. After stopping the operation, all facial muscle responses recovered rapidly. This is our setting of park bench position with skin incision like this, recently L shape. Drilling of the posterior wall of the IAC should be sufficient enough to expose the dura mater by 180 degrees to allow optimal provision of light, as well to get the space to enable the use of many kinds of dissectors. 7 gates I call are the fundus, both sides of the IAC, both shoulders. This is the important area for continuous facial monitoring, and this is the area for internal decompression. We believe most of the vestibular schwannomas are subarachnoid tumors. So after moving the double layers of the arachnoid membrane toward the brainstem, there is some very thin arachnoid membrane on the tumor. So about the tumor capsule, Professor Sasaki wrote that the tumor capsule consists of vestibular nerve fibers and perineurium. So this is the ideal dissection plane for tumor total removal and preservation for of facial and cochlear nerve functions. This is our case, and after total removal of the tumor, we can see the facial and cochlear nerve beyond the membrane derived from the vestibular nerve. It's not an arachnoid because we can see veins. About the 3 dissection planes, this is the arachnoid membrane, this is the facial and cochlear nerve, and this is the membrane derived from the vestibular nerve and tumor itself. So we can select 3 dissection planes like this. So right side, so after internal decompression, I found the rootic zone of the facial nerve, and I started the continuous facial nerve monitoring, internal decompression. I'm following the facial nerve. I'm opening the internal auditory canal widely and deeply. Using electrified microsurgical dissectors, I found the facial nerve. So this is the very thin cochlear nerve. And this is a membrane derived from the vestibular nerve, different planes. And this is the naked, transparent facial nerve. And I'm leaving the vestibular nerve fibers on the naked facial nerve. So these are the different planes. And also, I'm leaving a tiny tumor on the facial nerve. So we can see the 3 dissection planes at the same time. And also in this case, we can see the arachnoid membrane beyond the tumor. So this must be the perineurium of the vestibular nerve covering the facial nerve, and I left the tumor around here. In this case, with a very small tumor, so if I elevate the tumor, we can see the membrane from the vestibular nerve like this. We can see it. In this case, we can see the facial nerve beyond the membrane from the vestibular nerve. I'm moving the tumor like this. And we can see the membrane from the vestibular nerve covering facial nerve. Tumor was totally removed. And we can see the electrode for continuous facial nerve monitoring. I'm elevating the tumor very gently using a surgical cotton ball as a cushion like this. So we can see the facial and the intermediate nerve beyond the membrane from the vestibular nerve. I'm elevating the tumor and I cut the membrane from the vestibular nerve. And so I didn't touch the facial or cochlear nerve directly. So this is our set for microsurgical instruments for skull-base surgery. And I love using SS forceps. Right side. So I'm doing a pressure dissection using Kamiyama scissors. And this is the SS forceps, and I'm scraping and opening the brace. We can see the widespread facial nerve, grasping, open the brace. So we can do everything with this simple forceps. And finally, tumor was totally removed. We can see the 5th nerve, facial nerve, and 6th nerve, and the electrode for continuous facial nerve monitoring. Next, CP angle tumors, meningiomas, sorry. I approach from 3 directions like this. Retrosigmoid approach, most frequently, combined transpetrosal approach, and anterior transpetrosal approach. This is the distribution of types of CP angle skull-base meningiomas of our patients. Pituitary, petrous, jugular, posterior petrous, sinodural angle, clival, foramen magnum. About the approach selection. So for petroclival or pituitary meningioma, we use the combined transpetrosal approach most frequently. For tentorial, I use the anterior transpetrosal approach mainly. And for the other types, so I did the retrosigmoid approach. Totally like this. For pituitary or pituitary meningiomas, we use the combined transpetrosal approach, leaving semicircular canals. In this case, with the left pituitary meningioma, after removing the mastoid surface, I'm doing the mastoidectomy like this. I'm thinning the covering bone. Video doesn't work so well. I'm sorry. We can see the semicircular canals. I'm cutting the middle fossa dura, and also I'm cutting the tentorium. So we can see the 7th and the 8th cranial nerves here, internal decompression, and we can see the 4th and the 5th cranial nerves. And I'm opening the internal auditory canal, 7th and 8th cranial nerves here. So we can see the basilar artery, 6th nerve, 4th nerve, 3rd nerve, pituitary stalk. So tumor was nearly totally removed. Next, in this case with the petroclival meningioma, I selected the combined transpetrosal approach, but venous drainage is so much into the pterygoid plexus, so it's so-called a dangerous pattern for middle fossa approach. So to preserve venous drainage, I used the modified anterior transpetrosal approach reported from the Keio University group. This is the standard anterior transpetrosal approach, epidural approach, and this is the modification of the anterior transpetrosal approach with subdural and epidural combination. So I used the transmastoid and modified anterior transpetrosal approach, combined approach. So we can see the venous systems, what we want to preserve. So I cut the posterior half dura, and I'm drilling the Kawase's triangle. And this is the epidural, and this is the subdural area, and we can see the venous systems. I cut the tentorium, and we can see the 4th nerve, and I'm elevating the tumor, and this is the 5th nerve. Finally, I saw the 3rd nerve. So tumor was nearly totally removed. So jugular foramen tumors. So jugular foramen schwannomas accounts for nearly half of the jugular foramen tumors I operated. So I'll talk about the most frequent jugular foramen schwannomas. According to the type classification from the Professor Fukushima's group, for type A, intradural tumor, we use the retrosigmoid approach. And for type B, dumbbell-shaped tumor, or type C, triple dumbbell-shaped tumor, we use the transmastoid transjugular approach. For type C, I add the high cervical exposure. Regarding the roots for jugular foramen tumors, retrosigmoid approach has two options of retrosigmoid suprajugular approach and infrasigmoid approach. And transmastoid transjugular approach has also two options of transmastoid suprajugular approach and transsigmoid approach. Using this illustration of triple dumbbell-shaped tumor, so this is so retrosigmoid approach and retrosigmoid suprajugular and infrasigmoid optional approach, and transmastoid suprajugular approach and transmastoid transsigmoid approach, like this. So we reported about the retrosigmoid suprajugular approach, as Ken Matsushima said. And in this case, with the intradural type, we use the retrosigmoid approach, left side. So after identification of the vagus nerve, I started the continuous vagus nerve monitoring. We can see 8th nerve and 5th nerve and 7th nerve here. So after total removal of the cisternal portion, I am drilling the superior part of the jugular foramen. So we can see the jugular foramen here. And I'm taking the foraminal part of the tumor. So this is the final view. So tumor was nearly totally removed. And this is the area of bony drilling. Vagus nerve monitoring was preserved 44%, and lower cranial nerves was functions were okay, and hearing improved from the class D to class A. About the infrasigmoid approach, so after jugular, drilling of the jugular process, and after cutting the condylar emissary vein and marginal sinus, elevation of the sigmoid sinus allows us to enter the jugular foramen. Left side in a dumbbell-shaped tumor. So firstly, I did a partial mastoidectomy, and we can see the jugular valve and the condylar emissary vein and the internal jugular vein. And through the retrosigmoid approach, I took the tumor, tenth nerve here. So after that, I cut the condylar emissary vein, and I'm doing the elevation of the sigmoid sinus, and I can reach the foraminal part of the tumor like this. So probably hearing disturbance improved to the normal condition. So about the transsigmoid approach, many big names use this approach. And in this case, with a triple dumbbell-shaped tumor with a large extracranial part with left sigmoid sinus occlusion, I used the transsigmoid approach. After high cervical exposure, I'm drilling the mastoid area. And so we can see the large extracranial part here, 11th nerve and internal jugular vein here. I cut the intrajugular jugular vein and reflect it towards rostrally. And I'm ligating the sigmoid sinus and cut it. So this is a transsigmoid approach. Now I'm approaching to the extracranial part. So tumor was totally removed. And this is a big tumor cavity here. So in this case with a dumbbell-shaped tumor, so I use the transmastoid suprajugular approach. After mastoidectomy, so this is the sigmoid sinus here. I'm drilling around the jugular valve. So this is the foraminal part of the tumor, and this is the jugular valve. I'm cutting into the posterior fossa dura, and we can see the cisternal portion of the tumor. So we can see the 10th and 11th nerve here, and I started the continuous vagus nerve monitoring. So this must be the glossopharyngeal schwannoma. So internal decompression first. So we can see the 7th and 8th cranial nerves here. Next, I'm approaching to the foraminal part. This is jugular valve. So finally, tumor was totally removed. So vagus nerve monitoring was preserved 93%. Lower cranial nerve function was okay, and hearing was preserved. So about the continuous vagus nerve monitoring, we reported this method recently. And if we preserve more than 30% of the M marks, the lower cranial nerve function would be good. Lastly, mastoidectomy, our method, we make outer bar holes outside the operative field behind the sigmoid sinus. And these outer bar holes make us possible to dissect between the sigmoid sinus and the covering bone first. And after that, we can remove the covering bone using many kinds of longules. So this method is quite safe and speedy for exposing the sigmoid sinus. Left side, these are the outer bar holes. Video doesn't work, sorry. But we can see the lateral semicircular canal, and so I connected two outer bar holes, and I'm doing dissection between the sigmoid sinus and the covering bone first, and exposing the sigmoid sinus, and so we can see the semicircular canals here. And I'm cutting the middle meningeal artery, and we can see the GSPN, and I'm doing anterior transpetoroidal approach. So this is a typical combined transpetoroidal approach view. So we should care about the preservation of venous drainage if I cut the tentorium. So when we cut the SPS, not here, but here, ventrally to the entry point of petrosal vein. So it's method from the Osaka City University group. So in this case, with the left Cipiang epidermal cyst, so I use the combined transpetoroidal approach, and this is the mastoid emissary vein. And we can see the GSPN, and I'm doing the anterior transpetoroidal approach. And we should remove this area to enlarge the surgical field. This is the endolymphatic sac here. And I'm cutting the posterior fossa dura, preserving endolymphatic sac. So I'm searching for the petrosal vein and found it. So I ligated the SPS ventrally to the entry point of the petrosal vein. We can see the fourth nerve here. 7th and 8th cranial nerves here. And we can see the 6th nerve, and we should take the tumor, the membrane, to avoid recurrence. And finally, I opened the microscope, and I took the tumor totally. So post-operative course was uneventful. So in conclusions, key points of surgery, I think, are the continuous facial nerve monitoring in vestibular schwannoma surgery, selection of surgical approaches in Cipiang and skull-based meningioma surgery, and selection of surgical approaches and continuous vagus nerve monitoring in surgery for jugular foramen tumors. Thank you for your attention.
Wonderful lecture.
Thank
Truly
you.
amazing and amazing expertise. Thanks for sharing with us. We have a couple of questions for you, Dr. Kono. One is about where to find the electrode for continuous facial nerve monitoring. I guess they're asking where to find it. Do you have any recommendations or tips about that?
Japanese company provides its unique medical.
I know, you mentioned Dr. Jugular a couple of times in your lecture, which I've had the privilege and the honor of working with during my 2 years at Stanford. He's a truly master of this field, and I enjoy very much working with him. And he used to employ continuous facial nerve monitoring, but he doesn't do any longer. I am not sure exactly why. Maybe we can have him come up at some point and explain. But there is another question about what are your recommendations on closure following mastoidectomies? Do you like to put the outer cortical bone back in?
Yes.
You like to do a cosmetic mastoidectomy?
Yes, that's true. And of course, also I use the pedicled, so subgallial flap to prevent CSF leak.
Of course. Is it pedicle to the occipital artery posteriorly, or is it pedicle to the STA anteriorly?
No, just not a vascularized flap, but so just so pedicled flap.
Okay. You mean like a graft?
Yes.
Yes. Very good. Excellent. Wonderful lecture. Thank you so much.
Thank you.
Let's move on. Since we're a bit behind of schedule, we have now Dr. Matsuo, who is going to share with us microsurgical anatomy of the pineal region. We're going to change topics a little bit. We're going to come back to transpetrosal approaches soon and jugular foramen, but let's move into the pineal region, a little bit higher up.
Okay, can you hear me?
Yes. Okay. We have 2 lectures on the pineal region. First is Dr. Matsuo. As we said, this meeting is a lot about sharing fellows and masters. So we have a younger fellow, Dr. Matsuo, showing beautiful work. And then we have a master on pineal region, so Dr. Cohen-Garol, showing his expertise afterwards. Dr. Cohen, you want to make any comments?
No, I think I want to thank, first of all, for giving me the opportunity to be here, Juan Carlos, and just mention something about Dr. Rhoton. God bless his soul. He's truly has been such a role model for so many of us. And he has done so much to improve surgery and microsurgery in so many levels. Something that truly was inspiring about him was the passion he had for microneurosurgery and really attention to detail and the outcome, and truly was so dedicated to his patients and their outcomes. And I think that's truly something that all of us are so much inspired by Dr. Rhoton, and we'll remember him for that forever. Also, I want to really take a moment and thank Juan Carlos, who has truly been one of the most loyal and impressive proteges of Dr. Rhoton. And Juan Carlos, you have not only proven yourself to be an incredible master microneurosurgeon, you have proven yourself to be a master neurosurgeon. I think microanatomy is such a small part of your career, even though you have contributed so immensely. I think yourself as a master neurosurgeon have inspired all of us, and I truly appreciate Juan Carlos for putting this together.
Thank you, Ara. Those are very kind words.
You're welcome. And Dr. Matsuo, please go ahead.
Okay, thank you. Can you see my slide?
Yes, sir.
Yeah.
Thank you, Chairman. Dr. Fernandez Miranda and all of the members organizing this meeting. Thank you for giving me a chance to give a presentation in this meeting. It's a great honor to be here. Hello, everyone. I'm Satoshi Matsuo from Japan. Today, I'd like to talk about microsurgical anatomy around the pineal region. I have no financial relationships to disclose. Here is the outline of my presentation. First, I'm going to review the basic anatomy around the pineal region. Then, I'm going to show the surgical anatomy of the 2 common approaches to the pineal region, which are the occipital transtentorial and infratentorial supracerebellar approaches. This is the medial view of the right hemisphere. As you can see in this figure, pineal gland is located almost center of the brain. It is positioned inferior to the splenium, posterior to the third ventricle, above the collicular plate, and anterior to the Cavernous. This deep region is also referred to as the posterior insular space. Let's get into more detail. This is the enlarged view of the former slide. I'm going to start with the third ventricle. The roof of the third ventricle is formed by the fornix and two layers of the terra colloidea. The terra colloidea attach to the stria medullaris thalami. The space between two layers of the terra colloidea is called the verum interpositum. The internal cerebral vein and medial posterior choroidal artery, which is the branch of the PCA, pass through this space. The stria medullaris thalami blends into the habenula, and the habenula forms the habenular commissure. It is the upper half of the attachment of the pineal gland to the thalamus. The posterior commissure is the lower one. At the anterior margin of the thalamus, the body of the fornix separates into two columns. The columns of the fornix pass around the superior and anterior margin of the foramen mondo and turn downwards toward the mammillary bodies. The superior and inferior colliculi and the vermis of the lingula and cerebral mesenspheric fissure, which was formed by the cerebellum and midbrain, is positioned inferior to the pineal gland. The Cavernous is located posterior to the pineal gland. It may obstruct surgical access to the pineal gland through the infratentorial approaches. Next, I'm going to review anatomical relationships. This is the posterior view of the posterior insular space. Tentorium and cerebellum has been removed. As you can see in this figure, both PCA and SCA, and as well as their branches, courses through the posterior insular space. When approaching to the pineal region through the infratentorial approach, usually the PCA and SCA are less likely to be damaged than the veins, because these arteries do not cross posterior to the pineal gland as do the veins. This figure shows the inferior view of the hemisphere. On the right side, a part of the parahippocampal and the hippocampal gyruses have been removed. The PCA arises at the basilar bifurcation and encircles the midbrain, passing through the crural and ambient cistern to reach the posterior insular space, and usually bifurcates into its terminal branches, the parieto-occipital and calcarine arteries. The medial posterior choroidal artery usually branches off from the P2 segment. It courses lateral to the pineal gland and enters into the verum interpositum. From the medial side, here we can see the course of the parieto-occipital artery. It courses along the parieto-occipital sulcus. The calcarine artery usually courses inside the calcarine sulcus and sends branches into the inferior cuneus and lingula. The SCA also arises from the basilar artery near its apex, passes below the oculomotor nerve, and encircles the brainstem. As it courses posterior, it passes below the trochlear nerve and above the trigeminal nerve to enter the cerebellomesenspheric fissure. After leaving the fissure, the artery gives rise to branches that supplies the tentorial surface of the cerebellum. The SCA usually arises as a single trunk, but occasionally arises as duplicate trunks. Now, I'd like to move on to the venous relationships. The venous relationships in the posterior insular space is one of the most complex in the brain because the internal cerebral and the basal veins and many of their tributaries converge in this area. This figure shows the right posterolateral view of the posterior insular space. As you can see in this figure, the vein of Galen and its tributaries passes through the posterior insular space. The vein of Galen causes below the splenium to empty into the straight sinus at the tentorial apex. Among the tributaries of vein of Galen, I'd like to touch on the internal cerebral vein and basal veins. This figure shows the superior view of the lateral ventricles. The body of the fornix, choroid plexus, and terrachoroidea on right side have been removed. The internal cerebral vein originates from just behind the foramen Monroe by the union of anterior septal and thalamostrate vein. Then it passes through the velum interpositum to enter the posterior insular space. Then the vein joins its contralateral one and forms the vein of Galen. This is the superior view of the tentorial incisura. The basal vein is formed below the anterior perforated substance by the union of anterior cerebral and deep cerebral veins. The basal vein courses posteriorly between the midbrain and temporal bone to reach the posterior insular space. Then the vein usually empties into the vein of Galen, but occasionally it empties into the internal cerebral vein. Up to here, I have reviewed basic anatomy around the pineal region. Now, let me move on to the surgical approaches to the pineal region. The occipital transtentorial and infratentorial supracerebral approaches are two most common approaches to the pineal gland. I'd like to begin with the OTA. This is the posterior view of the right occipital and parietal lobe. The surface of the anterior part of the occipital lobe is drained by both posterior parietal and posterior temporal veins. The area around the occipital pole is drained by the occipital vein. They are usually directed forwards rather than medial or backward, so that no large veins around the trochlear. Therefore, usually the occipital lobe can be retracted from the palx and tentorium without sacrificing bridging veins. Retracting the occipital lobe from the palx and tentorium provides access to the ipsilateral splenium above the vein of Galen and to a part of the quadrigeminal system. To expose the lesion inferior to the splenium, dividing the tentorium is required. Dividing the tentorium and dissecting the arachnoid over the quadrigeminal system exposes the pineal gland, the superior and the inferior colliculi, trochlear nerve, and the vein of Galen and its tributaries, including internal occipital, basal, internal cerebral, and superior Birmingham veins. A steep tentorial surface may limit access to the cerebromesencephalic fissure. The internal occipital vein, also known as the anterior calcarine vein, drains medial side of the occipital lobe and particularly calcarine sulcus. Damaging this vein can cause postoperative visual field defect. Approaching from more parietal side or an angled endoscope, as in observing the cerebromesencephalic fissure. Here you can see below the inferior colliculus. This is the superior medullary velum, which is the roof of the fourth ventricle, and the origin of the trochlear nerve is here. Now I'm going to show a case briefly. The patient was a 57-year-old man with multiple metastasis. The largest cystic lesion compressed the brainstem and cerebellum, and he manifested ataxia. We planned the partial removal of the cystic tumor through the OTA to relieve the compression to the surrounding tissue before radiation therapy. Besides approaching to the pineal region, the OTA is commonly selected to the lesion involving the tentorial surface close to the brainstem. We usually place the patient in prone position and rotate it toward the approach side after dural opening. Placing the patient in prone position and approach from right side. For a less experienced surgeon, identifying the venous structures through second arachnoid membrane covering the quadrigeminal system is difficult. To avoid damaging the tributaries of vein of Galen, I usually dissected the arachnoid a little bit far from the quadrigeminal system, such as around the PCA and the pericallosal veins. Here's perineum. This is gonna be pericallosal vein. Before CSF evacuation, great care should be taken when retracting the occipital lobe to avoid damaging the optic radiations. IC green video angiography is helpful to identifying the tentorial sinus and the tributaries of the vein of Galen through second arachnoid membrane. This is PCA and tributaries are here. Dividing the tentorium exposes the quadrigeminal system and tentorial surface of the cerebellum. Dissecting the arachnoid membrane exposes a part of the tumor. Here you can see the pineal gland. After partial removal of the tumor, you can see the inferior colliculus, the origin of the fourth node, and part of the supramedullary velum. Here you can see the vein of cerebral mesenteric fissure, also known as the precentral cerebral vein. To avoid post-operative visual field defect, careful retraction was needed when retracting the occipital lobe. After the operation, his ataxia was improved, and he was referred to other hospital to receive radiation therapy. Post-operative visual field defect is one of the well-known complications after OTA. Understanding the cause of the optic radiations is important to avoid this complication. This figure shows the medial and inferior views of the left brain. Optic radiations has been exposed by fiber dissection technique. The blue area indicates the fiber. After leaving the lateral geniculate body and the pulvinar, the optic radiations causes an anterolateral projection and then turn backward. The fibers cover the roof of temporal horn, lateral lobe of the atrium, and the occipital horn, and then reach the calcarine cortex. The optic fibers have anterior, central, and posterior parts defined by the direction the fibers projecting from their origin. Differentiate these three parts with the fiber dissection technique is difficult. MRI tractography can clearly show each part from origin to termination. Both techniques help us understand the cause of the fiber. Now, I'd like to move on to the surgical anatomy of the infratentorial supracerebral approach. This approach has midline and off-midline routes. The off-midline routes include paramedian, lateral, and far lateral routes. Significant venous trunks obstruct surgical exposure at two levels in this approach. The first is at the level of the vein across the infratentorial space to empty into the tentorial sinuses. The second is at the level of the quadrigeminal system. This figure shows the suboccipital surface of the cerebellum. The inferior Birmian vein drains the vermis and part of the tonsil. They ascend along the vermospheric fissure and drain into the straight or transverse sinuses or the trochea. Through the midline approach, these veins may need to be retracted or sacrificed to reach the pineal gland. The inferior hemispheric vein originates from suboccipital surface, ascend and cross the margin of the suboccipital and tentorial cerebral surfaces and drain to the tentorial sinuses. These bridging veins would be less likely to be encountered in the paramedian and far lateral routes than in lateral routes. There is considerable variability in the site of these bridging veins. In the left figure, the inferior hemispheric vein drains a large area of the suboccipital and tentorial surfaces. On the other hand, the inferior Barmian vein drains a large area in the right figure. Dividing the vein, which drains relatively large area, can cause serious complications such as cerebral swelling and hemorrhagic infarction. We should consider the drainage area of veins before dividing them. This figure shows the midline root at the level of the quadrigeminal system. In this root, the superior Barmian vein is aligned with the pineal gland. It may be needed to be retracted or sacrificed to approach to the pineal gland. The steep angle of the Cavern limits the exposure around the auricular plate. Strong retraction may be required. This slide shows the off-midline roots. There are several advantages of the off-midline roots. First, as they move further laterally, the angle between the superior Barmian and internal cerebral veins and provides access to the gland, often without venous sacrifice, with the exception of the small tributaries, such as pineal and auricular veins. Shifting from midline to off-midline also provides a better view around the auricular plate and the origin of the trochlear nerve than the midline roots. In addition, the off-midline roots requires less retraction of the cerebellum. However, the palmar and tentorium can obstruct the surgical exposure in off-midline roots, especially for lateral root. In addition, off-midline roots prevent access to the lesion extending forward in midline from the pineal gland. Now I'm reaching the end of my presentation. Today, I review the basic anatomy around the pineal region and show surgical anatomy of the two most common approaches to it. Familiarity with the details of this anatomy is crucial to access to the pineal region. I hope my presentation helps you understand the anatomy. Thank you, Dr. Rhoton. Thank you for your kind attention. Thank you very much.
Thank you so much, Dr. Matsuo. A very revealing and obviously beautiful anatomy
Thank you very much.
of the region. Juan Carlos, if I can proceed, is that okay?
Please go ahead, Aaron. As we said before, your contributions, Aaron, to the field of neurosurgery are absolutely remarkable, far-reaching. I know you have in your atlas 30 or 35,000 people, subscribers. I myself am a subscriber. I'm sure many of you. Thanks for developing this. I know this is a lifetime effort and a resource for neurosurgeons all over the world, junior, senior, at all levels. So thanks, Aaron, and we are always happy to support you.
Thank you. Before we start, Juan Carlos, as the Neurosurgical Atlas has been a very fun project for us, I want to bring the attention to the neuroanatomy section. This is actually one of Juan Carlos' images, beautifully dissected. The function we have here is really incredible in terms of understanding anatomy. This is very interactive. In other words, as you go over the image, the structure highlight on their own. And if you click on it, all the other structures that are in our 2000 image collection, including the 3D anatomy, comes up. So this interactive structure that highlights everything in real life for you has been tremendous in terms of learning the anatomy. And then obviously you can bring it up on any structure, another one that's relevant, and then everything again is highlighted. And then if you click on a structure, the 3D anatomy comes up in even virtual reality setting. And in virtual reality, you're able to zoom in into the neurovascular structure of the brain, be able to rotate and see very deep, in 3D how everything works. Also, they're annotated as you click on it based on vein of Rosenthal, and then all the structures in 3D, all the images in 2D anatomical, and all the structures have been labeled. In addition, all the neuroanatomical operative cases will show up at the bottom of the image. essentially every image at any moment can search up to 15,000 structures by one click within the atlas, which is an immense resource and an ability to be able to use this very powerful search function to use it. So I highly recommend our colleagues in Far East, Japan, China, who haven't used this tool, please do use it. It includes Rhoton, Dr. Fernandez Miranda, Pablo Rubino's, and many of our other colleagues' images that we have really enjoyed working on. And any input you guys have to make this resource better is much appreciated.
I would add, Aaron, if I could, that I've actually tried those digital models you guys created, which are wonderful. I tried them in a VR virtual reality set. And that takes the anatomy to another level. Imagine you can go immerse yourself into the anatomy. You're within the skull base and you can actually go through the supraorbital fissure, for example, and things like that. It is another dimension to explore and understand the anatomy. And
I agree. There is the 3D stuff has been very fun. Maybe if we have a moment at the end, I'll show you some of our advanced 3D that are showing up soon, would be available. But I'm going to go ahead and focus. I'm going to probably have until 10 because we're a little bit behind. How much time do I have, Juan Carlos, just to keep us on time?
You have 20 minutes.
Okay. Thank you, Juan Carlos. So pineal region surgery is really an area that I love to operate through. It's deep. The anatomy is pristine. You enjoy not only the anatomy, the microsurgery. It contains everything that an anatomical or microneurosurgeon likes to enjoy. I'm going to briefly mention the legacy of Harvey Cushing that so many of us in North America admire. And I think Dr. Rhoton was truly of a similar power and impression on neurosurgery in that respect. I reviewed 15,000 records of Harvey Cushing. This is actually the first patient who underwent pineal region surgery. You can see his picture before surgery, the Pineal syndrome. Cushing unfortunately could not localize the tumor at the time. When the patient passed away in the hospital a couple of months later, he harvested the brain and recognized most likely this pineal region tumor that was, I think at the time was germinoma, because there was also tumor within the suprasellar area. So this is actually the first patient that we know what we have image of with pineal region mass within the North America. Doing pineal region tumor is nothing new. Over 100 years ago, Walter Dandy operated on puppies through the interhemispheric posterior interhemispheric approach, transcostal approach. So although it's we have always talked about new ways to approach the pineal region, it's actually relatively simple, new, it's not a new area. This is just something from the atlas showing our model. Something that our team has worked within the past 5 years. We have had 3 computer graphics artists working full-time. Actually, we're working on the avatar with James Cameron. So highly talented people doing our computer graphics work. The atlas, we briefly discussed 520 chapters, 1,200 videos, 150 grand rounds, 3,000 web pages, and to date, we have 42,000 members and 2,000 viewership per day. I'm going to go through pretty quickly about, anatomy of the pineal region and then run into surgical approaches. I love to sit during surgery. I always show this video. I use the mouth switch very often, very liberally.
Aaron, would you mind going to the presenter mode?
Okay, absolutely. I'll be happy to. Thank you for mentioning that. Does that help you better?
Yes.
Okay.
Thank you.
Thank you, Juan Carlos. So I like sitting. I think it's especially important for pineal region surgery. Using the mouth switch is so critical, and it allows you to work without using your hands to adjust like what I'm doing here, and using the armrest to be able to rest your arms and really feel very much in control and save energy as you're working. So one of the papers that I discussed surgery within the pineal region is this paper in Brokaw's area, which is The Art of Microneurosurgery and Passion for Technical Excellence, something that Dr. Rhoton has instilled in so many of us. This is a paper, actually, we work with Ken Matsushima that I have a lot of respect for. At the time, he was working with Dr. Rhoton, and he's with us this evening. And it describes my philosophy for approaching pineal region tumor. The past 10 years, I've never approached, no matter where and how big within the pineal region. I have never used the midline suboccipital approach. I always use the lateral supracerebellar approach that Dr. Matsuya also referred to, and I will try to emphasize why this is so important. Why is the lateral supracerebellar approach, or the paramedian one, so critically advantageous compared to the midline one that so many people are using? Again, these are other papers that posterior transcostal approach we describe with the group at Sims-Murphy, with Paul Klimo and Dr. Rick Boop, and also the group of with Dr. John Robertson and Jeff Sorensen. Presentation of pineal region tumor is standard. I'm not going to go through that. Those are very simple. The analysis and study imaging, we all know very well. Obviously, these are lesions that could be diagnosed through CSF or endoscopic third ventriculostomy and biopsy, and one has to be very careful not to operate on granuloma or lesions that can be typically managed otherwise. These lesions can really look very similar within the pineal region. Here is, for example, a pineoblastoma. This is a germinoma. They look exactly the same. This is a hemorrhagic pineal region glioma. And obviously, knowing where the vein is, the vein of Galen is in relationship to the tumor is critical in operating in this area. Obviously, pineal region masses include a pineal cyst that rarely we operate on, and a pilocytic astrocytoma in this area. Again, the algorithm, how to diagnose these, evidence of hydrocephalus, serum markers, and serum markers if they're negative or positive, and the biopsy and adjuvant therapy are very standard and are very familiar. Dr. Matsuya went into detail about how we can approach this area. This is very deep, and when the moment something is very deep and difficult to get, every surgeon tries to describe their own approach. I do believe that the lateral paramedian supracerebral approach is essentially the only approach. In 95% of cases. There will be 5% of cases where you may have to use the posterior transcostal approach, but really using this approach that I'll cover today is extremely advantageous, very panoramic, very flexible, very efficient, and minimally invasive, and provides you all you need to approach the area. We talked about the midline supracerebral approach. 95% of neurosurgeons use this approach. However, the Coleman is going to be obstructive, and you're going to have to take a fair number of midline veins that were discussed in the lecture before me very elegantly. However, the paramedian approach has many advantages, and I'm going to repeat that multiple times. So number one, the approach is less invasive because you're really exposing and manipulating one transverse sinus. You're not manipulating the toricula, and it's a linear and paramedian incision in between the inion and the mastoid groove. And because the craniotomy is very small and you're not worried about manipulating the toricula, it can be done very quickly. It's really small and effective. Because this is so deep, the size of your craniotomy really doesn't have that much relationship to what you're doing deep, because again, the angles are more important than the operative space. And there are occasionally places where you need to go a combined approach, which is very rare, a tirovelar and a supracerebellar approach. So number one, the advantage of paramedian is you avoid, it's efficient and it's minimally invasive. Number two is you avoid many of the midline veins, and that's critical. Why is that critical? Because often when you go supracerebellar, you're forced to take some veins cerebellum swells a little bit, you have to retract more, the retract causes more venous congestion, cerebellum gets more swollen, and it becomes a vicious cycle. You just can't see around stuff, and it becomes very difficult. The lower inferior slope of the cerebellum really provides you a more exposure of the posterior brainstem and a cross-core approach to the pineal region. It's another incredible advantage. And so number one was minimally invasive. Number two was avoiding the midline veins. Number three was you're using the advantage over the lower slope of the wings of the cerebellum. And really the next advantage is that you really can work between the veins. In other words, really the anatomy of the vein, a vein of Galen, Rosenthal, all those veins don't matter anymore because you're not going to take them. In this approach, you're going to go cross-court. The only disadvantage is that it can be disorienting to the surgeon, and because the third ventricle is as an angle to you, and I'm going to review that momentarily. So we talked about the paramedian approach. The surgeon experience and comfort level in this area is very important. I've done over about 145 pineal region tumors. Essentially 141 of them have been done through the paramedian approach, even if they're through the third ventricle, and it shows the flexibility and the utility of this approach. Obviously, the texture of the tumor, how vascular it is, how suckable it is, all of those are very basic in terms of doing that. This is my personal series that was recorded a while ago, 120 cases. This is the distribution of the cases that I have done. Really a beautiful area to operate on. It pushes our limits in every way. It's deep and it's very, very beautiful microanatomy. This is the midline approach, which everybody's very familiar here with. Again, one important point is that if you follow the tentorium, at some point you have to change your angle inferiorly. Otherwise, you'll be looking at the vein of Galen and could injure them. Just remember that as a nuance. That's very important. This is something we wrote up a while ago. If you remove the bone over the transverse sinus, you can really move the sinus out of your way and tuck it up by putting two sutures on the underneath surface of the tentorium and just mobilize that superiorly. So this is absolutely my favorite. We talked about that. This is a beautiful dissection from Dr. Matsumoto, from Ken, describing the approach. You can see that as you come laterally, from Dr. Matsushima, coming laterally on the left, you can come in, you can preserve the veins here, you can see the pineal region, very panoramic, very flexible, beautiful approach. You don't have to fight the resistance of the midline Coleman. This is an illustration from Josh Klein, who will talk to us tomorrow, extremely talented illustrator. As you can see from the detail of his work, reminds me of our Japanese colleagues' dissections. And you can see the approach to a tumor, the veins are preserved, and you can really do a cross-court approach. Exactly the same principle as removing a olfactory groove meningioma through a terional approach rather than a bifrontal approach. Here's the anatomy when the tumor is ghosted. I want you to see the anatomy of the third ventricle. It comes at an angle towards you. Here again, you see the third ventricle is in the direction we're talking about. If you go deep, you're going to hit the contralateral third ventricle wall, and that's why I want you to be very careful when operating through this region. Again, beautiful illustrations from Josh Klein showing the anatomy of the region, the veins, how you're working between the veins rather than taking them as you go. And here's the third ventricle anatomy ghosted in. Again, these illustrations are so important to orient the surgeon as you're going through the anatomy and removing the tumor. Here you can see the anatomy of the fourth nerve. You can see the tumor and the third ventricle you're looking at. Again, we reviewed these briefly, how it minimizes retraction. I'm going to go ahead and review this video. This is can you hear the audio, Juan Carlos, of the video, or is it only my audio you can hear?
We cannot hear it.
Okay, beautiful. So here is the paramedian approach. I also position the patient lateral. I also use stealth neuronavigation, have a point available for ventriculostomy if I need to. You can see the incision, the anatomy is very standard. We'll go ahead and further forward. Here you can see, let me show the, here the exposure. You can see the trochlear nerve, the posterolateral aspect of the brainstem. This is looking on the edge of the tumor on the right side. The tumor is open, it's debulked, and then it is disconnected from the area of the septum. You're looking through the third ventricle and then debulk the tumor further. And then if it's very adherent, you can leave a very tiny sheet of tumor. This is vein of Galen, really a beautiful view, no retraction. Everything is very dynamic in terms of mobilization of the cerebellum. And in this case, a small sheet of the tumor was left on the vein of Galen. And here is the end of the resection, looking at the contralateral tectum, and shows radical subtotal resection of the tumor with just a small sheet of the tumor. Again, very minimal retraction of the tumor. And it's amazing how well these patients do in terms of lack of cerebral retraction during surgery. Occipital transtentorial, there is a place for it. I think in my personal, again, opinion, it's very small. It just takes so much and you have to disrupt so many normal structures to get to it. And if you're using dynamic retraction, it is so effective to work right at the area where you're working, rather than having a fixed retractor that actually obstructs your view because it provides a very indiscriminate retraction, injures the cerebellum, and you can't even see as much exactly where you're working, where the suction tip can provide you with more exposure. It is utilized for tumors arising from the precentral cerebral fissure, posterior cerebral space, and adjacent structures. It is favored if the D veins are displaced posteriorly. However, I don't find that to be necessary to consider if you're using the paramedian approach. Obviously, a multi-compartmental lesion would require such an approach, which is very rare. Again, these are images from the Rhoton collection demonstrating the approach through the interhemispheric approach. This is the way I approach it, and then cutting the tentorium, getting there really provides a very flexible approach as well. But again, much more invasive. This is the anatomical variations of tumors we have seen. The posterior interhemispheric transclosal intravenous paravenous approach, something described by Walter Dandy quite a while ago. It's for a tumor such as this, that a majority of the tumor is actually in the third ventricle. Very rare tumor where you come interhemispheric transclosal and you're able to remove the tumor within the pineal region as well. This is illustration demonstrating the approach within the interhemispheric transclosal approach, going with it between the posterior interpharyngeal columns and watching for the internal cerebral veins and removing the tumor. And again, this shows the really reach of this approach within the green area. This is a tumor where we use this approach, a very giant recurrent epidermoid, and this is the positioning lateral. Again, the angle of the neck is 45 degrees to the floor, and it really provides a beautiful approach. I'm going to briefly go over the video. Here you can see again the reach of the tumor. This is very small linear incision for the interhemispheric approach. You open the interhemispheric space, avoid the trollard, you stay behind the trollard, and then you most of these tumors make the callosum attenuated, so you can go through the callosum without significant side effects. At this point, you enter the tumor, and after that, it's nothing but just fun because you can really play with the tumor, enjoy the anatomy, and be able to remove the tumor very effectively. This is my personal reflections that I want to just briefly mention. Juan Carlos is, as I've learned in microneurosurgery, and the passion Dr. Rhoton had for doing microneurosurgery, is that a neurosurgeon has to monitor their own individual maneuvers. We all should have situational awareness. In other words, there is if you think of us as a computer during surgery, there's one level of processing where we're doing these surgical things and are enjoying the moment, but there's another layer of processing where we're watching ourselves. It's called situational awareness. You're almost it's an out of body experience, and you're watching yourself and can be much more critical and reflective. I think a master surgeon, many of whom are present this evening, there's a certain level of automatic monitoring that we can have during surgery, where we can automatically perform surgery without thinking too much about it. And that increases our bandwidth or capacity to have that situational awareness. And that's the mastery of technique, where you can do the surgery essentially almost in your sleep, as we say it in English. But in fact, there is another layer of processing and power above that, where you can go beyond, where the novice surgeon is so much focused into that step-by-step parts of the operation. So reflection in action, I think, is such an important part of microneurosurgery. Again, these are personal reflections on master of neurosurgery that I want to share with you, unrelated to pineal region surgery. The novice surgeon has a very formulaic, very step-by-step level of thinking that much of bandwidth of the processing of the brain is focused on that step-by-step operation, and much less is left for that situational awareness. I personally think the most common reason for a mistake in microneurosurgery is there's a gap between what is expected and what's observed in surgery. And because the surgeon has so much of his or her bandwidth focused on what he or she feels should expect, they miss actually their ability to deal with unexpected. And because they don't have an agenda ready for that, they will make the pathology fit their agenda rather than their agenda fit the pathology, and that can lead to significant errors. Surgical wisdom, learning, acquiring experience, reflective practice. There are many surgeons and there are many right techniques, but avoiding dogma, remaining innovative, doing every surgery differently as needed to make it better, beautiful, safe, as Dr. Rhoton said, and really using that anatomical microsurgical knowledge that we have as anatomists, and be able to be flexible and creative to provide new innovative approaches to deep lesions are some of the advantages we have as an anatomist. So again, I want to thank you for an opportunity to be here and to be part of this great group of surgeons. Thank you, Juan Carlos.
Thank you, Aaron. That was wonderful. The honor is ours to have you with us and sharing your pearls of wisdom, not only technical pearls, but also wisdom pearls, which are so important. We have, as we go to the next speaker, a few questions. We have someone, actually it's not a question, but it was just, they were commenting on how you're such an excellent narrator because of your calm voice. Something that I think we all agree with. Is easier to follow you because you, and Dr. Rhoton had that too, you know, that calm voice, speaking slowly, so everybody can understand anywhere you are in the world. So that's just a comment. Then we have another interesting question. This is always a topic in pineal region surgery. And this question actually comes from Dr. Goyle, who is, an absolute expert in this area, about the sitting position versus lateral position versus prone position. So I know how you think, but you want to share with us your thoughts about sitting position versus lateral? Or versus prone?
Thank you, Juan Carlos. And I think our Japanese colleagues can also share their comments here, as well as Dr. Goel, who is with us tonight. I'm sorry if I'm forgetting someone. The sitting position is beautiful. I think it's very advantageous. I trained in it. However, in the United States and North America, because of the liability, the anesthesiologists feel uncomfortable with it. And because of that, we have had difficulty convincing our colleagues to do that approach. The other thing about this sitting position, which is a disadvantage, is that your arms are hanging. I know Professor Yashargil had this innate ability to operate in a sitting position that it seems like many of us don't have as much or can develop it right away. So because the arms are hanging in the air, or even if you're resting it in the head of the table that's bent and attached, still it's more difficult to have a very steady hands. I think there's no question the sitting position provides more exposure to the lateral brain stem through the Pineal approach because of gravity retraction. But based on the request of anesthesiologist, again, it's dependent if your institutional experience with the anesthesiologist is different. I hope that answers the question. What do you think, Juan Carlos?
I agreed. I actually, you know, during my time in Pittsburgh, I started doing some sitting position cases. They had never been done there for the last 20 years or so. And it was a big deal to get all the equipment, the anesthesiologist ready. But I partnered with an excellent anesthesiologist, cardiovascular anesthesiologist, to do these cases. But, you know, later I started switching more to lateral, and I find that it's not such a big difference in my opinion. Sitting is perhaps a bit better in terms of space, but a good lateral position with good cisternal opening provides, I think, more ergonomic position for the surgeon and good working space. I think maybe Dr. Goel can share, if he wants later, his wisdom with us on this topic. So we have a few other questions. We might have to leave some of them for the end because we are running a bit behind. I want to ask next Dr. Lieber, Stefan. He's somewhere in Europe. Maybe he can tell us where he is, and it's midnight in there, or not midnight, but it's maybe 4 a.m. or something like that. But I'm very glad he's joining us. Dr. Lieber, as we said before, in this meeting we joined fellows and masters. He was a fellow with me in Pittsburgh for years and doing phenomenal dissection work. And now he's been a fellow in Germany. And please, Stefan, come up and share with us your screen.
Yes, wherever you are, I just tried to share my screen, which doesn't seem to work here. Good morning, good evening, wherever you are.
We can barely hear you.
With me, so I apologize if I don't.
Stefan, we can't hear you, we can't see you.
All right.
We can see you actually, but we cannot hear you. Maybe your volume needs to go up.
Yeah, that's...
Dr. Goel, while Stefan fixes that, do you want to make a comment on the sitting position since I see you there, Atul? You are muted. There you go.
The sitting position, you know, I can understand that there are limitation by the anesthetist and limitation by the rules and all those things. But if you really ask me, there is no question and no doubt in my mind that sitting position gives you an absolutely different world for this region surgery. That is one point. Second thing is, I understand about, you know, your hands getting stretched and your hands getting up and all those things. But, you know, the bottom line is if you are going to prolong the surgery for 8 hours, 10 hours, then of course, then this issue may come up. But if you're reasonably quick, I think this issue is not such a great thing. But the dissection, the imaging, the ease of surgery is far superior. You see, I have done bilateral position and all those positions, but sitting position, believe me, even, you know, I understand that sitting position is not at all the norm in acoustic neurinoma surgery, for large acoustic in particular. If you ask me if my sitting position for large acoustic tumor is such a fantastic position to, you know, to deal with the tumor, deal with the bleeding and all those things. So those are my points, Juan.
Great points. We very much value those.
Thank you.
Can you hear me all right now?
Stefan, we can see your screen. Just go to the presentation mode. I think your volume, there is something wrong with your volume. See, you can maybe come closer to the computer screen, or are you using headphones? Maybe that's a problem.
I'm not using
I think the headphones will really help.
Do they help?
They might help if you have headphones with microphone.
Yeah. Can you hear me now?
Not very loud. Maybe if we can perhaps all of us turn the volume up. Try now.
Very sorry about that.
Okay, this is better. This is better now.
A bit and to shuffle a bit closer to the screen. Maybe that works. Just keep reminding me if it's not working for you, okay?
No problem. This is good.
Perfect. Thank you. So the screen is shared for you all?
Yes, so I wanted to, Stefan, to just give a brief presentation, 15 minutes on how beautiful dissections can get, and we know this from Dr. Rhoton, but this can be replicated at other labs, and I wanted to leave Stefan to share with us. Please go ahead.
Thank you. So I was asked to give this brief overview mainly about the transcranial perspective of petroclival anatomy. Obviously, this is a lot to cover, and since I went through the schedule, there's specialist talks by fantastic faculty. I'm quite humbled to be part of this. So I try to be quick and not to cover too much in double. So obviously, talking about the petroclival lesion, we're talking about the sphenoid, the petrous, and the occipital bone. And the most, can you see my pointer here? You can't see a pointer, right?
We cannot see the pointer.
All right. So we're talking, yeah, this is, okay. So we're talking about the lingual process, right? The extension of the petrous carotid, the landmark for the lacerum segment, foramen ovale, foramen spinosum. We're talking about ovale here, foramen rotundum, and the petroclival fissure. These are the main landmarks for the petroclival lesion. And then here, the internal acoustic canal, the jugular foramen, hypoglossal canal, then the depressions of the superior petrosal sinus and the trigeminal, the porus trigeminus, and again the petroclival fissure, which is also the cause of the inferior petrosal sinus. And this is then the dural coverage with all the cranial nerves protruding. You can see everything from cranial nerve 3, then entering 4, the tentorium, right down to 12, the hypoglossus, right down here in the condyle. I will not go, I think this has been covered earlier today. I will not show a lot of endoscopic pictures. I will also not follow the rule of third, because this has been covered extensively. I'll show some of the superior sphenoid, and then cover which has not been covered so much in the other talks. So this is a transcranial endoscopic perspective, and this is the superior aspect of the suprasellar region. And here we're just talking about the superior epiphyseal artery. Cannot see any direct McConnell perforators, but here it's the superior epiphyseal artery coming off the supraclenoidal ICA, and it usually has 3 stable branches. And you can see the infundibular part, and the chiasma, the chiasmatic branch, and then the branch running with the optic. Usually these are 3 stable branches. This is just a detail of the oculomotor triangle in preparation of the lateral cavernous sinus wall, formed by the anterior and posterior petroclenoidal ligaments. And again, this is a lateral perspective. And we see here mostly the tent, which has been cut in all the cranial nerves 6, 4, 5, and right up to the optic and the olfactory bulb. So this is mostly about the perforators, or the branches, the inferolateral trunk and the meningopophyseal trunk coming off the ICA, the cavernous ICA, the C4 segment, which you can sparsely see in the tentorium following 4. And this is just a posterior dorsal perspective of the dorsum celli. You can see Gruber's ligament, which is the connection of the petrosphenoidal ligament, which also forms part of Duralis canal here, 6 running forward. You see the trigeminal ganglion reflected laterally, and you see these branches coming off the carotids. You have the laterally, you have the infralateral trunk, which usually has 2 branches, and then you have the meningopophyseal trunk, which gives off the inferior epiphyseal artery, then the dorsal meningeal branches to the clivus, and then a varying number of tentorial and lateral tentorial marginal arteries, venas coni, carcinaris. All these arteries are coming off either separate or off the trunk of the meningopophyseal. This is easier. Obviously, this is not a surgical perspective. This is a pure anatomical dissection from a mid-sagittal dissection. On the left side, the carotid has been resected just to show the infralateral trunk and the meningophyseal trunk, you can see running posteriorly the tentorial artery, and running with the abducens nerve just under Grubus ligament. You can see the clavicle arteries, the meningeal arteries, which sometimes in petroclavian meningioma can reach a significant diameter. This is one of the few endoscopic pictures I want to show because it's just so much more easy to visualize. These are the inferior hypophyseal arteries. You can see 6, and the clival branch coming off the meningophyseal, and then right between the abducens nerve on the right side of this picture, you can see the aspect of the infralateral trunk running with V1. And then once you medialize the anterior genu of the ICA, you can actually see coming off the infralateral trunk, which usually has 2 branches running anteriorly and inferiorly to the superior orbital fissure of rotundum and ovale. This again is an endoscopic picture depicting the abducens nerve, the interdural course of the abducens nerve, which the mobilized Grubus ligament, which again is part of the roof of the Rhotos canal. And this is 6 running behind the carotid on this side. And again, that's the transdural intracranial or cisternal perspective of 6 ascending and then entering the interdural aspect. This is just a general overview of the main vasculature of the posterior fossa. I think this is fairly known anatomy, just the vertebral basilar system with the labyrinthine and sometimes subarcuate arteries running into the internal acoustic canal. You have a duplicated SCA on one side, and this is probably just known anatomy. You see the superior petrosal sinus running in the incisura and merging with the basilar plexus in the cavernous sinus. I think this has been covered in a previous talk about microvascular decompression. I will not go into too much detail with this, just for the sake of time. And this is in preparation for the petrosectomy part. Just a view into the middle fossa. On the right side, you see the tentorium at the level of the colliculi running anteriorly and entering the tent. Again, the oculomotor triangle, a superior petrosal sinus covering the porus trigeminis and the middle meningeal artery and the floor of the middle fossa. This is again just to show the cavernous carotid and the branches coming off of it. Again, you see the meningophyseal trunk with these branches, and again you see Grubus ligament covering the abducens nerve. And also the beginning landmarks. The left aspect of the picture, you see landmarks of Kawasi's approach, the anterior petrosectomy quadrangular space. You see the middle meningeal, GSPN, and the arcuate eminence. This is again a reflection of the trigeminal ganglion. Now you can see attaching to the lingula of the sphenoid on the right, you can see the petrolingual ligament, which again is the landmark for the petrous ICA to become the short lastrum ICA, and then the cavernous ICA. Again, Grubus ligament covering 6, GSPN, and a nearly dehiscent petrous ICA. This is not a surgical view of the Kawasi's approach, but it's depicting most of the anatomy of the Kawasi approach. You have the porus trigeminis, you have the tendon largely removed, and the superior petrosal sinus still covering it. You see the contents of the internal acoustic canal, 7 and 8, and the intermedius. You see the genu, the labyrinth, cochlea exposed, GSPN, petrous ICA running medially. So this is these are the landmarks, the petrous ridge, GSPN, V3 anteriorly, and then cochlea and labyrinth as the posterolateral margin of the approach. This is now switching to the posterior fossa. Again, an anatomical perspective, not really a surgical view. on the right-hand side, subcerebellar or retrosigmoid exposure you would get here. You see the ascending branches of 11. You see 12 in the middle, right over the before segment of the vertebral artery, and you see 9 and 10 ascending to the jugular foramen. This is again, this probably has been covered by Max Nunes' talk about brainstem anatomy. These are just the cranial nerves, the oculomotor nerve protruding from the interpeduncular fossa. Then you have 4 running around the midbrain, the level of the superior colliculi. In the brachium pontis, you have 5. Then the pontomesencephalic fissure, you have 6 ascending cysternally. And then going from medial to lateral, you have facial intermedius and vestibulocochlear nerve. And then post and pre-olivary sulcus, you have 9, 10, 11, and 12, and then the C1 rootlets further down. This is again another perspective on the right-hand side, mainly focusing on the internal acoustic canal and the jugular foramen. See even 5 in the petrosal vein complex in the superolateral aspect of this image. And again, you can see the posterolateral sulcus, post-olivary sulcus, where 9 and 10, 9, 10, and 11 are extending from an anterior to the olive. You can see the various rootlets of 12 descending to the upper glossal canal. This is yet another detail with a bit more vasculature. You see the flocculus and the labyrinthine artery entering the internal acoustic canal. You see, again, before segment, you see the pica loop, the tonsillar loop on the left-hand side of the picture. And this is the beginning of a transmeatal approach. The exposure of the vestibulocochlear nerve, intermedius and facial nerve in the internal auditory canal. This is the usual distribution within the canal. This picture, we have a labyrinthine artery. We have not a subarcuate artery, which usually ends in the petrous face, in the posterior face of the petrous bone in this level. And again, this is a focus on the jugular foramen on the other side. With the ascending fibers, you see there's 2. There's a nervous, there is a venous part and a nerval part, depending on the classifications, either 2 nervous compartments or 1 nervous compartment. And the glossopharyngeal is entering the jugular foramen separately on the superior aspect, which is better seen here. So you have this dural ridge, which connects with the petrous and the occipital crest of the jugular foramen, and separates the nervous part of the jugular foramen into 2 aspects. You see the ascending common trunk of the accessory nerve, and anteriorly, in an anterior direction, you see the hypoglossal fibers descending to the hypoglossal canal and the occipital condyle. This is yet another focus on the vasculature. You see the medial and lateral segment of the pica, and then further down you have the tonsillar segment and the before segment of the vertebral artery in the background behind the hypoglossal nerve. And this is just the extracranial extension here, looking into the obex, the extracranial perspective of the contents of the hypoglossal canal and the jugular foramen. And as I understand, the next talk will be on jugular foramen, so I thought this would be a nice picture to finish this rapid overview, to keep the schedule, and to show some anatomy of the petroclavian region. I'm very grateful for this talk, for all the mentors. Fantastic time in Pittsburgh. Obviously, the mentorship I received from Juan, from Paul, and Carl, the friends I made. I have to thank Maximiliano Nunes, who's also faculty on this course, for lending me some of his fantastic pictures and all the friendship and colleagueship we shared over the years. And also many thanks for my my new mentor, Sebastian and Paris, with whom I started just working this year. Hopefully there's much more to come in the next years. Thank you very much.
Thanks, Stefan. I think that was beautiful, and I believe inspiring for some of the younger attendees in the audience. Some of them are commenting on your beautiful illustrations, and some of them are asking on giving us, can you give us tips on how to take such clear, clean, and shining cadaveric images? First, I would say, and Dr. Rhoton used to say this, he didn't like the word cadaveric when we're doing dissections. Some people even call cadaveric lab. I hated that name because we're not doing cadaveric dissection, we're doing anatomical dissection using cadavers or specimens, but this is anatomical dissection. And it's such an art, as you have nicely demonstrated. You're gonna give us a couple tips?
Well, you see it in every Rhoton paper. It's a mix of the circumstance. So you have to have good quality from photography, from preparation, from injection. The specimen has to be in a good state. So I think it's everything coming together. And then you have to be patient and do the dissection and have a plan also for the dissection. You should know what you want to achieve with the dissection, when you just want to follow surgical steps, or whether you want to dissect everything in layers as in an anatomical dissection. That's how I studied my dissection in your lab. Was mostly understanding the anatomy and then following in later stages, more following surgical approaches.
Fantastic. Beautiful. For those in the audience interested, just please join us tomorrow. We'll have a full session on lab work and some of the techniques. As Dr. Lieber mentioned, everything is important, from having a high quality specimen to do very careful meticulous dissection, to then take perfect photography of those dissections, and then even post-processing of the images can also help. So Stefan, thanks so much.
Thank you for having me. Yeah.
You may go back to sleep now, and
I'll follow, and then I'll follow you some more tomorrow. Thank you very much.
Very good. I will see you. We'll see you later. So please stop sharing your screen, Stefan, so we can go into our next speaker. I think we have again Dr. Sorenson, and hopefully Dr. Robertson is still with us, although I know acknowledge is maybe quite late. But Jeff, please go ahead and share your screen.
Okay, so we're going to talk about the jugular foramen, and particularly the lateral transmastoid approach to the jugular foramen. And we're going to use some of those beautiful works of art from the Rhoton collection. And I must say, Stefan's dissections were beautiful, and I've seen a lot of dissections, and those were outstanding. We're going to use some of those that shows the anatomy very well, and we'll use some surgical footage that it's more difficult to appreciate the anatomy, but it illustrates some technique of dealing with pathology. And then we'll show a little bit of cadaver footage too, that sort of in between those two extremes, and we'll see how that goes. So I'm going to go ahead and start showing this footage here. Can y'all see that?
Surgical access to the jugular foramen is difficult because of its deep location and the surrounding neurovascular structures blocking its exposure, such as the internal carotid artery anteriorly, the facial nerve laterally, and the vertebral artery inferior to the posterior medial margin of the jugular foramen. Therefore, skull-based lesions of the jugular foramen should be approached as a surgical anatomist would to preserve the complex neurovascular structures of this region. Benign tumors are the most common pathology affecting the jugular foramen region. The majority are chemodectomas, neurolimomas, or meningiomas. Rarely, chordomas or chondrosarcomas may involve the jugular foramen, as well as other malignant tumors. The type of pathology and the extent to which it involves the neurovascular structures of the jugular foramen region will determine the selection of an approach to the jugular foramen. Rhoton has categorized approaches to the jugular foramen into three groups. A lateral group directed through the mastoid bone. This would be the postauricular transtemporal approach. A posterior group directed through the posterior fossa. This would include a retrosigmoid or a more extensive far lateral or transcondylar variant approach. And finally, an anterior group of approaches directed through the tympanic bone. This would be the preauricular, subtemporal, infratemporal fossa approach, or variations of that. In each of these approaches, a neck dissection can be included as needed to manage the specific pathology that one is dealing with. A preauricular, subtemporal, infratemporal approach will be necessary for management of tumors involving the internal carotid artery and the anterior jugular foramen. The retrosigmoid approach involving a far lateral transcondylar exposure is needed for jugular foramen tumors occupying the posterior fossa or foramen magnum. Our presentation is focused on the most common approach to the jugular foramen, the postauricular transtemporal approach combined with a neck dissection. The goal of this video is to demonstrate the surgical anatomy of the postauricular transtemporal approach to the jugular foramen region. Combined with a neck dissection, this is the most common surgical approach chosen for management of lesions involving the jugular foramen. The labyrinth is usually preserved in this exposure, but depending on the pathology, the surgical field may be extended anteriorly by transposing the facial nerve and sacrificing the middle ear structures and external auditory canal, or medially by removal of the labyrinth or cochlea. We are viewing the inferior aspect of the right skull base in the region of the jugular foramen. The postauricular transtemporal approach, combined with a neck dissection, allows a 270-degree exposure of the jugular foramen at the skull base. This would include anteriorly exposing the internal carotid artery to the level of the carotid canal. Laterally, the styloid process and the facial nerve at the stylomastoid foramen. And posteriorly, the full extent of the rectus capitis lateralis muscles attachment to the posterior margin of the jugular foramen, which represents the jugular process of the occipital bone. The case that we're presenting for illustration of the technique is that of a 65-year-old lady who presented with pulsatile tinnitus, a normal lower cranial nerve and facial nerve function. Her hearing was also intact on the left side. Neurodiagnostic studies included an MRI scan as well as CT scan revealing a 3-centimeter glomus jugulare tumor with destruction of the mastoid bone primarily and the region of the jugular bulb by the glomus jugulare tumor. The cerebral angiogram on this individual demonstrated significant blood supply from both the left external and vertebral arteries, typical of a glomus jugulare tumor. There was no blood supply to the tumor from the internal carotid artery at the skull base. Preoperatively, the patient underwent embolization the day prior to surgery. The patient was placed in a supine position with an ipsilateral shoulder roll and the head turned away from the surgeon. Our cadaver dissection begins with the sharp dissection of the sternocleidomastoid muscle from the mastoid tip. The sternocleidomastoid muscle is carefully mobilized posteriorly. Care is taken to preserve the accessory cranial nerve, which enters the posterior medial aspect of the superior sternocleidomastoid muscle at the level of the tip of the C1 transverse process. This Rhoton dissection shows the relationship of the anatomy of the sternocleidomastoid muscle to the posterior belly of the digastric, facial nerve, and styloid process. These anatomical structures are viewed clearly in this particular dissection because the parotid gland has been removed. A specific anatomy to be noted in this view is the facial nerve exiting the stylomastoid foramen immediately anterior to the posterior belly of the digastric, attached to the digastric groove. Also note the styloid process can be seen clearly, and the facial nerve exiting in the stylomastoid foramen along the posterior lateral margin of the styloid process. Note also in this view the accessory nerve crossing the anterior margin of the jugular vein to enter the posterior medial aspect of the sternocleidomastoid muscle. The posterior belly of the digastric muscle is sharply dissected from the digastric groove of the mastoid tip and mobilized inferiorly. Removal of the posterior belly of the digastric muscle from the digastric groove allows exposure of the facial nerve at the stylomastoid foramen. This also allows palpation of the styloid process and the three small muscles attached to the process. Stylomastoid foramen is found at the posterior lateral margin of the styloid process base. In this view, the stylohyoid muscle has been retracted to expose the styloid process. The stylohyoid muscle is being reflected inferiorly along with the posterior belly of the digastric muscle. The styloid base can be palpated anteriorly and posterior to the facial nerve as it enters the stylomastoid foramen. We also see the facial nerve entering the posterior aspect of the parotid gland, which has been partially removed for exposure. Here one sees the stylomastoid artery, which typically arises from the posterior auricular artery. Now, the stylomastoid artery should be preserved because of its blood supply to the mastoid segment of the facial nerve. Here, the facial nerve is retracted anteriorly to expose the extent of the styloid process. Removal of the styloid process is necessary to expose the internal carotid artery immediately below the skull base. This should be done when the internal carotid artery is encased by the tumor or provides an arterial blood supply to the tumor. Removal of the facial vein allows exposure of the carotid bifurcation. The hypoglossal nerve is identified typically at the level of the bifurcation or immediately above the bifurcation as it courses medially to the base of the tongue. It is noted that the accessory nerve can typically be found at the level of the tip of the transverse process of C1. The accessory nerve can pass either anterior or posterior to the jugular vein at this level. The occipital artery is mobilized and removed in order to gain exposure of the upper cervical region. The jugular vein is mobilized superiorly, exposing the carotid bifurcation, the vagal, and the hypoglossal nerves. The external carotid artery is retracted to allow exposure of the internal carotid artery. The internal carotid artery is exposed immediately below the skull base. The ninth cranial nerve can be seen at this level crossing the anterior margin of the internal carotid artery. In this view, one can see the ninth cranial nerve exiting the medial aspect of the jugular foramen. This view also shows the fusion of the hypoglossal and the 10th cranial nerves as they approach the jugular foramen. The fusion of the lower cranial nerves can occur immediately below the skull base as they approach the jugular foramen. This may be true of any combination of the 10th, 11th, or 12th cranial nerves. In this extended dissection view of the high cervical area, following removal of the sternocleidomastoid, posterior belly of the digastric muscles, one clearly sees the ninth cranial nerve crossing along the anterior margin of the high internal carotid artery. The hypoglossal nerve is seen coursing immediately above the level of the carotid bifurcation as it travels medially towards the base of the tongue. The 11th cranial nerve is seen crossing the anterior margin of the jugular vein in the high cervical area at the posterior margin of the sternocleidomastoid muscle, which has been resected. Finally, one sees the vagal nerve as it courses between the internal carotid artery and the jugular vein. Attention is turned at this stage of the procedure to the mastoidectomy. The anatomical landmarks to be identified include the supramastoid crest, superiorly, posteriorly the asterion, which provides localization of the junction of the transverse sigmoid sinus and exposure of the sigmoid sinus. Anteriorly, the spine of Henle should be noted to provide the location of the vertical segment of the facial nerve, the mastoid portion. Here we're drilling along the posterior semicircular canal. The chorda tympani is identified. One now sees the facial recess to find between the superior aspect of the mastoid segment of the facial nerve and the chorda tympani. Drilling through the facial recess opens the middle ear space. The superior aspect of the mastoid segment of the facial nerve can be seen turning below the lateral semicircular canal anteriorly. The superior semicircular canal is further defined. The jugular vein must be mobilized to the level of the skull base in order to have full exposure of the jugular foramen. The 11th cranial nerve is found at the level of the tip of the transverse process of C1. If the 11th cranial nerve passes over the anterior margin of the jugular vein, as in this case, the jugular vein must be transposed anteriorly to allow dissection of the jugular vein to the level of the jugular foramen. This Rhoton dissection shows the relationship of the rectus capitis lateralis muscle as it arises from the superior surface of the transverse process of C1 to project superiorly, attaching to the posterior bony margin of the jugular foramen. The vertebral artery surrounded by its venous plexus exits the foramen transversarum is defined. This muscle is sharply dissected from the superior margin of the transverse process of C1 and then removed in a piecemeal fashion to the posterior margin of the jugular foramen. As one removes the rectus capitis lateralis muscle, one must be careful to avoid the vertebral artery which exits the foramen transversarum posterior medial to the rectus capitis lateralis muscle. Here we see the venous plexus associated with the vertebral artery. The lower cranial nerves are separated from the jugular vein to the level of the jugular foramen. Residual bone and the fibrous ring of the jugular foramen are removed.
That's where we showed it.
The jugular vein is opened through the jugular foramen. In an actual case where a tumor would involve the jugular foramen or jugular bulb region, one must isolate this region initially by ligating the jugular vein immediately below the skull base, followed by ligation of the sigmoid sinus distal to the junction of the transverse sigmoid sinus and the entry of the superior petrosal sinus into that junction. Ligation of the sigmoid sinus involves individual foral silk sutures that have passed from the outer wall of the sinus, attaching it to the inner wall of the sinus. And this is done in a serial fashion to cause occlusion of the sinus. In order to prevent bleeding during this procedure, the proximal portion of the sinus can be occluded by using bone wax packed underneath the edge of bone extending over the junction of the transverse sigmoid sinus. Unless the tumor has significant extension into the posterior fossa, which in this day is really quite uncommon because most of these tumors are identified when they're typically medium-sized or smaller tumors. The labyrinth, as well as the cochlea, are not involved with tumor, nor is the middle ear invaded by the tumor mass. But bleeding that is encountered should be controlled with either application of bone wax, cottonoid pledgets, or Surgisil. This represents the ascending pharyngeal artery, which is a significant blood supply to the glomus jugulare tumor. Here we're mobilizing and cutting the fibrous ring to open the jugular foramen along the lateral and posterior margin. At this stage, we're opening the jugular vein, which you can see, as you recall, glomus jugulare tumors typically arise at the dome of the jugular bulb and can be found both extra as well as intraluminal, where a tumor fills not only the jugular vein extending below the skull base, but completely fills that region of the jugular bulb with invasion of the mastoid bone at the level primarily below the labyrinth as well as the middle ear space and cochlea. As the vein is opened, one sees the typical appearance of the glomus jugulare tumor. The tumor is removed in a piecemeal fashion, extending up into the region of the bulb. As the tumor is removed at the bulb level, there is attachment of the tumor primarily at the region of the dome of the jugular bulb, as well as partially on the medial wall superiorly in that region. Involvement above the level of the bulb and below the labyrinth is carefully removed following definition of that tumor that has been removed from the bulb as well as the jugular vein itself. The tumor has been removed and the tumor bed is packed with Surgisil for hemostasis. This Rhoton dissection in a normal specimen shows the medial wall of the jugular foramen and bulb region and the lower cranial nerves that are covered by the medial wall with the various venous channels that represent the inferior petrosal sinus and condylar emissary drainage into the jugular bulb. Closure of the cranial defect is accomplished by utilizing a fat graft taken from the anterior abdomen. The graft is held firmly in place by a titanium mesh cranioplasty, which closes the cranial defect. The sternocleidomastoid muscle can be attached to the titanium mesh and the soft tissue of the neck dissection closed in a layered fashion. Post-op, the patient's hearing, lower cranial nerve, and facial function were normal. Her pulsatile tinnitus was no longer present. A 2-month post-op follow-up MRI scan of her head showed no residual glomus tumor.
All right, thanks to all the fellows here that did dissections that were included in that video. And again, a longer version of this video will be available on the Rhoton collection. Over here, Juan Carlos.
I'm sorry, I was muted. I was saying that such a beautiful demonstration of combining beautiful anatomy work done in Rhoton's lab with beautiful surgery done in the OR by Dr. Robertson. So phenomenal video put together.
Thank you.
And many of these resources are available for the younger audience on the Rhoton collection, which contains, as Jeff will explain tomorrow, most or a lot of the work that was done in Rhoton's lab, and is free available for anybody to use, not only for a consultation, but to download and use in talks, even in 3D presentations. You can watch it in your 3D TV at home if you have one. is just a unique, wonderful resource of, you know, a lifetime work by Professor Rhoton and all his fellows. So, or immense thanks to you, Jeff, for putting that together. Such an enormous effort that you know will stay for forever and for everybody.
Thank you, Juan.
Fantastic. So let's move on. I think we have now Dr. Ohata. Perhaps Dr. Matsushima or Dr. Kobayashi want to introduce him. I happen to know Dr. Ohata because I've been in Japan a number of times, and you know, he comes from the school of Dr. Hakuba, so it can be more traditional skull-based surgery than that, because skull-based surgery was started with Dr. Hakuba to a large extent.
Yeah.
So Dr. Matsushima, please go ahead.
Next speaker, Dr. Ohata, is you know, one of the leaders of the skull-based surgery. Especially, he is a specialist of the transpetrosa approach. He's still working at the Osaka City University. Yeah, as Joan told us, that he succeeded in the Dr. Hakuba. Yeah, please, Dr. Ohata, give us a lecture.
Okay, thank you, Professor Matsushima, for introducing me. So can you hear me and see me?
Yes, very well.
Okay, thank you, Professor Miranda, kindly inviting me to this Rhoton seminar. Rhoton is one of my mentor. Of course, he maybe didn't know well. So this is my topic, transpetrosa approach and surgery for petroclival meningioma. There's no financial conflict to report. So first of all, I want to clear the definition of petroclival meningioma. This meningioma located medial to the trigeminal nerve and the 7th and 8th nerve, involving abducens nerve. This definition is very important. Otherwise, you will confuse the approach and concept to the petroclival meningioma. There are so many kinds of the tumor around this region. Of course, some small one could be rejected by just a suboptimal approach, like Professor Torgo is doing. But if the large operation becomes so complicated. So first of all, I want to show my nightmare in this relatively small case. This is a 99-year-old female with facial numbness. And this is a tumor. This is a real petroclival meningioma. Size is not so large. Tumor located middle part of the petroclival region. I want to show the operation. I will access by a suboccipital approach on the right side. This is a sigmoid transverse sinus, sigmoid sinus. So this is a petrosal vein. And tumor surrounded by 5th nerve, 7th, 8th nerve, and lower cranial nerves. This is a reality of petroclival meningioma surgery. You must access the tumor through the cranial nerves. It's so difficult to remove the tumor without damaging this cranial nerve. This is a 5th cranial nerve, and this is 7th and 8th nerves. And if the tumor becomes large, there's a tight adhesion of the tumor to the brainstem. This is the basilar artery, and unfortunately, this tumor is so hard. So, and then we must go up. This is a tentrium. I perform the tentriotomy, preserving the 4th cranial nerves. This is the 3rd nerve. Always petroclival meningioma pushing the 3rd nerve anteriorly. This is the final stage of the operation. This is a nightmare for me. Or this is anatomically the cranial nerves are preserved, but patient lost the hearing and facial function. This is a MRI after operation. This is a photo of the patient 6 years after operation. Patient still have the facial weakness and hearing loss, of course. So this is nightmare for me. So the operation performed 25 years ago. One experience is so important for the young surgeon. So of course, The tumor is large. No wonder about to use transpetrous approach. Tumor is tightly adhered to the brainstem. If the patient is young, we must remove the tumor radically without causing the cranial nerve deficit. So this is Professor Hakuba report transpetrous approach to remove the petroclival meningioma in 1977. So this is a crime bureau textbook, and Professor Yasagir summarized transpetrous approach reported by Professor Hakuba. So this is an extension of the subtemporal approach have been described. And this is a modified translabyrinthine transtentorial route reported by Morris and King. And Professor Hakuba further modified this approach for neurosurgeon in 1977. It consists of a mastoidectomy and posterior petrosectomy and temporal craniotomy, suboccipital craniotomy, plus tentoriotomy. This is very important. You can mobilize a sigmoid sinus. And this is an operation record in 1980 by Professor Akira Hakuba when I became one of the resident under his direction. This is a surgical of the meningioma of the petrous tip. He mobilized the facial nerve already. This is a facial nerve. So this is a concept of the transpetrous approach. This is a basically epidural approach to the center of the skull base. We must mobilize sigmoid sinus. We must mobilize temporal lobe in the through the epidural space, and then tentoriotomy must be performed. So after tentoriotomy, we can mobilize sigmoid sinus and temporal lobe with dural sinuses. This is a very important. So there is, of course, limitation of the transpetrous approach. Lower limit is jugular foramen. So if we go to access to the medial to the lower cranial nerves, we must combine with the suboccipital approach. And anterior limit is retrochiasmatic space. So I want to mention the patient positioning. This is a spine lateral approach. When I operate in abroad, patients, if the patient is so fatty, I use spine lateral approach, but it's not convenient for surgeon. I prefer to use a park bench position. And this is a semi-prone park bench position is very important. After put the patient semi-prone, head rate rotate to the surgeon side, making the temporal plane parallel to the floor. In this procedure, we can avoid the shoulder in the vision. This is very important. Otherwise, if you put the patient straight lateral, if the shoulder is on the way to the region, this is very important. And the skin flap. This is a current our skin flap. It's very auricular skin flap. This is very nice. If you want to extend the skull, craniotomy anteriorly, you can put another incision, but this is good enough. And of course, we must put take harvest pericranial flap for the reconstruction. This is a skin incision in the real patient. This is a little bit long because we need a long flap. This is a pedicle fascial temporal flap. This is a temporal muscular fascia. This is occipital muscle. It's with pedicle to the sternocleidomastoid muscle. This occipital muscle connect the temporal muscle and the sphlerocleidomastoid muscle. This is very important. This is harvesting the temporal fascial flap. I want to show the video. This is a very important step. Otherwise, you lost a patient after operation due to the CSF leakage and infection. This is not vascularized, but this is pedicled. In some case, I stage the operation. First operation is for the just craniotomy, and I close the wound. And 1 week later, I reopen this fascia. It's become thickened. This is a vascularized already in 1 week. This is a very, very long, very long. This is no artery, no vein, but this is connect in 1 week. Don't worry about this. This is and then I want to show how to close a wound. This is the surgery of the petroclival meningioma. This is a fat to close the air cell. And then I put the temporal fascial pedicle flap, this one. This is a perfect flap. This completely covers the defect of the bone. Defects of the temporal bone is completely covered. So, and then harvesting the dissecting the photosynth, we must perform the temporal occipital suboccipital craniotomy. And I prefer to use a splitting mastoidotomy because after the operation in the chronic stage, patient complains of deformity of this area. And to sleep good, to have a good sleep, we need a mastoid process. That is why I like to reconstruct the mastoid process. And the next step is exposure of the sigmoid sinus. This is also very, very important step. So 40 or 30 years ago, we eggshell the sigmoid sinus. Eggshell and leave some small piece on the sigmoid sinus, and we remove the bone. But it's very dangerous. If you use a drill around the sigmoid sinus, sometimes drill jump to injure the sigmoid sinus. So we report all such complications. So for the last 30 years, we directly dissect the sigmoid sinus under the microscope and then rongeur out. Of course, this part is very dangerous. This is a mastoid emissary vein. This is a high risk of injury of the sigmoid sinus. This part must be carefully exposed by the air drill. I show the step. This is a live operation. This is a splitting mastoidotomy. Finally, we repair this with mini plate, and this is a dissection with a sigmoid sinus. So I observing this under my direct vision and put the dissector and rongeur out. This is very fast, very fast. If you try to expose the sigmoid sinus by drill, you need a lot of time and danger as well. And punch out, punch out, punch out, punch out. If there's a mastoid emissary vein, you must use a air drill, of course. So this is, and then next step is exposure of the middle skull base. This is a epidural peeling off technique. It's a well-known technique. This is a foramen spinosum, middle meningeal artery, of course, transected. And this is a imaginary explanation of the epidural exposure of the middle skull base. Each nerve has a dura propria. This is a dissection between the dura propria of the trigeminal nerve and the dura propria of the temporal lobe. That are loose areolar tissue. And after exposure of the temporal skull base, you must have an image of the whole structure inside the bone. That's a landmark middle meningeal artery, usually GSPN running on the surface of the temporal base, and the trigeminal nerve is visible. And you must dissect. And this is a view from the posterior aspect to the petrous bone. So this is a photogram. This is the middle fossa. This is a foramen spinosum coagulated and transected, and then GSPN must be exposed. This is a posterior surface of the posterior petrosal bone. Endolymphatic sac may be resected safely. I report this technique 35 years ago. all of the otolaryngologists said you patient may lose the hearing. No problem, no problem. I already deployed this technique. And then anterior surface, posterior surface has been completely exposed to have the orientation of the petrous bone. This part is so important to have a good anatomical understanding of the petrous bone during the operation. And my concept, our concept, reported by Professor Hakuba, and I follow his concept, is partial labyrinthectomy, if possible. This is a minimal petrosectomy approach, keeping the hearing intact. Labyrinth is partially opened, but this drilling is very important. You will gain the 1 centimeter on the surgeon side. It's very, so obtain the wider space in the deeper part. And I want to show the step of the petrosectomy. This is a lateral semicircular canal. After drilling the air cell, you may have the neural crest bone, very compact bone. This is a lateral semicircular canal. And posterior semicircular canal is partially opened and marked with a dye like this. And this is the lateral and the superior semicircular canal right here. And I perform the partial opening of the superior semicircular canal and the posterior semicircular canal to confirm the anatomy. And then internal auditory meatus is opened. And finally, if required, internal auditory meatus is partially opened. And then trigeminal impression should be opened. You may open the petrous segment of the carotid artery without damaging cochlea. Of course, there is some limitation. You must have a good orientation of the cochlea. If you drill it over, so you may damage the cochlea and the patient may lose the hearing. So orientation of the middle skull base is very important. There might be the facial nerve here. And next step, I'm sorry, transpectoral approach is very complicated. You must know the good anatomical orientation. The next step is a preservation of the venous system. This is a sigmoid sinus, transverse sinus. This is a superior petrosal sinus and the petrosal vein right there and the tumor there. Incision is like this. I'm sorry, very complicated. So key point is superior petrosal sinus must be cut as deep as possible in order to preserve the venous flow from the petrosal vein to the superior petrosal sinus to the sigmoid sinus. If you cut the superior petrosal sinus at the surface, this petrosal vein lost the drainage and patient may have the severe cerebral hemorrhage. So this is a very, very theoretical illustration to show the dural incision. I think you can see this figure after my lecture. So this is, superior petrosal sinus must be cut as deep as possible. Sometimes I cut the superior petrosal sinus around the Meckel cave. This is very important. And then, after at the point of the cutting of the superior petrosal sinus, I start the tentoriotomy. This is a trigeminal Meckel cave partially opened. Goal is cross around the dural end perforation of the trochlear nerve. And then you have the wide operation field in the intradural space. You can mobilize sigmoid sinus. This is not a combination of subtemporal approach and suboccipital approach. You have a wider operative field after tentoriotomy. This is developed by Professor Hakuba. And you can go to the retrochiasmatic space. And we have been removing the craniopharyngioma in this procedure. I want to show the case. I have already just 15 minutes. So this, I want to show some positioning. This is a posterior cranial process meningioma. This is one of the complicated petroclival meningioma. This is a positioning. This is a simple park bench position. Spinal drainage is necessary, and this all part is protected by a sponge. This is a middle skull base. I want to show how to preserve the emissary vein in this video. This is emissary vein, mastoid emissary vein. This is a sigmoid sinus right here. This is a very dangerous part. You must be carefully expose the mastoid emissary vein. If you radically remove this part, you can injure the sigmoid sinus, and patient have an awful post-operative hemorrhage. I want to show you final slide. So this is a very important stage, and now I expose the sigmoid sinus. This is a very important. As I showed already, this is a direct exposure of the sigmoid sinus, and punch out, punches. This is very fast, very fast. Believe me. If you like to see my operation, please invite me to your operation theater. I want to show you. This is this part, lower part must be exposed by the sigmoid drill because there is a suture. This is very dangerous part. So this is a posterior surface of the petrosal bone, superior anterior surface here. In this case, I just perform the conservative petrosectomy approach. Okay, this is a air cell. This is a mastoid antrum here. And this is a lateral semicircular canal, posterior semicircular canal, and anterior here. If you have just a neurosurgeon's eye, eagle eye, you can see this semicircular canal. This is a compact bone, and I dissecting the endolymphatic duct, and I perform the anterior petrosectomy. This is a combined anterior and posterior petrosectomy approach. This is this is just the same as a cadaver dissection, but easier than cadaver dissection because the brain is soft, but difficult because there's a bleeding. So this is now I start to remove the tumor. I have many cases. This is a retrochiasmatic space. Okay, I move on to the next case. This is a post-operation. There's no temporal lobe damage because this protected by the dura mater. I reduce the temporal lobe on the dura mater. This is very important. That is why I say concept of the transpetrosal approach is epidural approach. You must cut the dura as deep as possible. Dura protects the brain from your technique. So next, I want to show the mobilization technique of the trigeminal nerve. This is a macular cave opened. This is a not so large pedal-clyval meningioma, middle size. So I use a transpetrosal approach. This is this is a left-sided approach. This side, partial lumpectomy already performed. This is a macular cave is opened. This is very important because tumor located medial to the trigeminal nerve. After opening the trigeminal nerve, you can mobilize trigeminal nerve. This is a very, very good case to show the effectiveness of the transpetrosal approach. This is the abducens nerve. Shift superiorly, this is a 7 and 8, 5th nerve. There's a wide space because I mobilize this space. And then I insert the accusa. So, this is a 6th nerve. Good. Of course, the petrosectomy need 2 hours. Let me say 2 hours from the skin incision to expose the tumors. But after exposure of the tumor, you need just 1 hour, 2 hours to remove the tumor. If the Professor Goel operate this case, he will remove the tumor in 30 minutes. This is a 6th nerve. This is a 4th nerve. All cranial nerve is anatomically and functionally preserved as well. So this is the post-operation, of course, the small piece left behind. in the surgery of the petroclival meningioma, tumor must be left behind around the Dorello's canal. Otherwise, you may damage the abducens nerve. Professor Hakuba tried to remove the tumor from the Dorello's canal. I observed he damaging the abducens nerve. So when I become the operator, I never remove the tumor from the Dorello's canal. I leave the small piece around the Dorello's canal. This is a secret. This is a not so interesting phase, but this I good case to show how to perform the petrosectomy. This is a partial labyrinthectomy on the right side. This is a GSPN. There might be a genuine ganglion here. You must have an image. You must have an eagle eye. You know, eagle eye could be grown during the cadaver dissection. Very important. There's some distance left behind, and I open the macro case. And there is a wide space because no temporal lobe, because I retract the temporal lobe with dura mater. There's no risk of the temporal lobe damage because it's protected by dura mater. No, it's just no. And then there is abducens nerves here. There is abducens nerve. This is of course not total resection. This is a maximal safe resection. Some small piece left behind around the abducens nerve. This is after operation. This is this patient is a pianist. You know, pianist. He must have should not have any complication regarding the diplopia. And this is the last case. I want to show you. This is a real petroclival meningioma in 51-year-old female with gait disturbance. Patient come to my office with wheelchair. You know, this is very dangerous. I select the total petrosectomy approach. This is a very complicated approach. You must mobilize the facial nerve and then start to remove the tumor. This is a very complicated, time-consuming approach. So, of course, we may stage the operation. First stage is petrosectomy, and second phase is facial mobilization and tumor dissection. This is a facial nerve mobilization. After this technique, patient have a grade 3 facial nerve palsy. I'm sorry about that. This is a, this is a limitation of this technique, but we can save the all other cranial function and brainstem function. This is a very dangerous. This is a opposite six nerve. This is a basilar artery. You know, if we continue to dissect the basilar artery, we may injure the ipsilateral abducens nerve. We must know where to stop the operation. And of course, this is a very, very tight adhesion. So this is a facial nerve. This is a ICA. We have a wide space. We can perform the maximal dissection without causing dangerous complication. This is a final step. This is operation. Of course, total resection is impossible, but we remove the tumor maximal and keeping the important function intact. This is 6 years after operation. Patient come to my office with a wheelchair before the operation, but patient come to my office by herself from the local area of Japan. This is a very important function. Is all totally because of course seventh nerve palsy has partially take place. So finally, I want to show you one of the serious complication I already mentioned. Serious complication is injury of the dominant side of the sigmoid sinus. This is taken from my report in the Journal of Neurosurgery in 1998. I analyzed 143 cases, and 7 cases has a sigmoid sinus occlusion after the operation, and some are symptomatic. Some is one non-dominant side occlusion caused no symptom, of course. This is a occlusion of non-dominant side sigmoid sinus. There is some minor edema. This is the dominant side. Patient has a severe temporal hemorrhage. Patient become vegetative state. This is a nightmare for me. This operated 30 years ago. That is why Professor Hakuba organized a Venus conference in Japan. This is dominant side, but there is some communication between both transverse sinuses, so complication is minimal. This is I want to show the outcome. Some patient. This is some case total resection is impossible. Of course, we are not God, but we must keep the function intact. And then this is another case is some small piece left intact. So this is a real petroclival meningioma, some part left behind. Of course, we need the support of radiologists, neuro-oncologists, of course. This is my conclusion. Transpetrosal approach continue to be an essential procedure for the surgery of petroclival meningioma. Thank you very much for your attention. Thank you.
Thank you, Professor Ohata. That's an impressive experience that you have with petroclival meningiomas. And I think many of us totally agree that combined transpetrosal is a key approach to have in our armamentarium as skull-based surgeons. I do have one question because I know you work with Dr. Goto, with Takeo Goto, who is a good colleague, and we're gonna hear from him tomorrow. And I was very impressed about Takeo because he's your disciple. He trained with you on transpetrosal approach, and he does perfect transpetrosal approach. But he's also learned to do endoscopic endonasal approaches. So what do you think, as such a senior and experienced surgeon, what do you think is the role for endonasal surgery for petroclival meningiomas? Think there is a role, or you think you are completely against it, or you think there are some cases that can be used?
So I like to use endoscope. I trained by Professor Duraf in Germany, 1990.
Yeah.
So I know the advantage of endoscopic endonasal approach, and I also know the advantage of open skull-based surgery. So we must take the benefit from both. This is we need a surgical IQ. This is my comment.
That's good. It is. I do believe that they both have a key role, and I guess I'm on my own. I'm learning when to use one or the other and how to choose. It's a learning process for sure. So tomorrow we'll hear more from Takeo. Thank you so much, Professor Hata.
Thank you. Thank you. Thank you, everyone.
Aaron, would you not make any comments because I see you there?
I think it's just beautiful work. These are very, very challenging cases. Some of those tumors that I reviewed, I'll tell you, that's incredible result. And it comes through a lot of patience, many hours of microsurgery, and great judgment of when to stop. I think anybody, after a while can learn to do the procedure relatively well, but just doing it right for such complex cases and have good judgment, it just requires a master surgeon. And I really want to congratulate you, Dr. Ohata, Professor Ohata. That's just magnificent work.
Thank you very much.
Thank you, Aaron. So our next speaker is Dr. Saito from Fukushima Medical University. He is organizing actually the Japanese Skull-Based Society meeting, which I'm happy to join. It's going to be virtual now, too bad we cannot visit. Dr. Matsushima, Dr. Kobayashi, any words you want to say about Dr. Saito?
No, you know very well now.
Okay, very good. Dr. Saito, welcome. Please share your screen. Go ahead.
Can you hear me?
Yes.
Okay. So can you see my slide?
Yes, we can.
Okay. So I'll present two endoscopic approaches to the brainstem in this presentation, but I'm a classic skull-based surgeon like Professor Ohata. So this work is done by my colleagues. See, Watanabe from Aichi Medical University, Kishida from Nagoya Daini Red Cross Hospital, Yusuke Sato from Osaka Municipal Hospital. They all used to work with me in Fukushima. And Tambara now in our university, and Takeuchi from Nagoya University. So I'm graduated from Nagoya University, and I learned skull-based surgery from Professor Sugita. And I moved to Fukushima 2009, from Nagoya to Fukushima. And all of you know that we have a earthquake 2012, 11, and also we had tsunami explosion of a nuclear power plant. But now Fukushima has recovered. I become now a vice president of Fukushima Medical University and the director of Fukushima Global Medical Science Center. This center was made to support the revitalization of Fukushima from the medical and health perspective, as we aim for a future the world can share. Anyway, endoscopic approach can provide wide and bright cross observation through the keyhole and small window. So this is a standard microscopic view of some subtemporal approach with a temporal incision or anterior petrosal approach. This is a view by a subtemporal endoscopic approach. This is the first case. We operated this patient 10 years ago. This was a patient with low-grade glioma. This is the cyst, and tumor was here like a mural nodule. So we decided to do dual endoscopic approach through right keyhole temporal craniotomy. This approach was published by Watanabe. We use two high-definition endoscopic systems, and through the keyhole temporal craniotomy, we insert 4 mm scope to observe the surface of brainstem. Then using a test-up needle with a 2.7 mm scope inside, we penetrated the cyst. Then we change to the cyst. We put the 2.7 mm scope in the cyst and remove the tumor using a forceps. So this is the drawing by Watanabe. I'll show the video in the next case. So this is pre-op again. You see this tumor located upper pons. And this is after surgery. Now 10 years after surgery, she has been well without tumor recurrence. This is another case, next case. 8-year-old boy with NF1. And because this tumor growing, so we decided to remove it using the same approach from left side. This surgery was done by Kishida. We made a small temporal craniotomy, and then using endoscope, we inspected subtemporal space. We made a temporary incision. Then here is the trochlear nerve. Using electrical stimulation, we map the position of pyramidal tract that is anterior here. Now we dissect and we map the pyramidal tract here. Then we decided this is the safe entry point. We made a small corticotomy. Then test-up needle was inserted into the region. Then needle was changed. Test-up needle was changed to the teeth. So this is a view of a 4 mm scope to observe the brain surface. Now this is a view inside of the test-up needle. We are now penetrating the brainstem to the region. And then we change to the teeth. And inside of the teeth, in a wet field, we started to remove the tumor. This is a view of dry field, but mainly we work in a wet field. During surgery, we confirmed the position of pyramidal tract using electrical mapping. and continued to remove the tumor. This is final view. We confirmed total removal and no bleeding. Again, this is a preoperative MRI showing the tumor is in upper pons. And this is post-op MRI showing tumor removal. Now 8 years after the surgery, no recurrence. This is the second approach I'll show you. This is the petrous tip endoscopic approach. The patient is a 68-year-old female with left hemparesis. She showed left hemparesis due to the hemorrhage from cavernoma here. We removed this tumor using epidural petrous tip endoscopic approach through right temporal keyhole. Then we made a temporal incision. This surgery was done by Takeuchi from Nagoya University. He came to our university and did this surgery. We made a temporal craniotomy, and then using endoscope, we elevate the dura from middle cranial base. So here is the accurate eminence. Using navigation system, we confirm the position. Then we drill the petrous tip. So we drill the petrous tip. This is exposed petrous dura. Using navigation, we confirm the exposed area. Here is the supraepithelial sinus. Then we cut the petrous dura to expose brainstem. We did not cut the tentorium. Here is the trigeminal nerve, and we expose the upper brainstem pons. Again, using electrical stimulation, we confirm the position of pyramidal tract, and we decided this is the safe entry zone. So we made a small corticotomy. Then we insert the test tap needle. Using navigation guide, we reached to the tumor here. And we changed to the fifth. And in a wet field, we started to remove the cavernoma. We dissect the cavernoma and removed it. This surgery, piece by piece removal. This is the wet field view. In a wet field, we can expand the tumor cavity. This is dry field view. Again, in a wet field, we further dissect the tumor. And we removed the tumor. This is final view in a wet field. We confirmed total tumor removal and no bleeding. Then we put a piece of surgical in the inside brainstem and partially sutured the dura and put the abdominal fat into the drilled petrous tip and corridor. So again, this is preoperative view, MRI, and this is post-op. You can see the fat we put. So this is the operative corridor. And this CT shows the drilled petra tip here. And this is craniotomy here. So this is the corridor we marked. Then we performed cadaveric study to confirm how much we can see the brainstem using this approach. So this cadaveric study was done by Yusuke Sato and Tambara. So through the temporal skin incision, we made a 3 centimeter keyhole temporal craniotomy. Then using endoscope, we elevate the temporal dura from middle cranial base. Then we confirm the position of middle meningeal artery, foramen spinosum, and we cut middle meningeal artery. In the previous surgery, of course, we did the same procedure. We cut middle meningeal artery and we exposed the petra tip. We elevated meningeal dura to expose the V3. And this is the position of GSPN. We further expose the petra tip. Then we drill the petra tip. We drill the petra tip like a standard anterior petrosal approach. But we did not cut the temporal dura, or we did not cut the tentorium. Through the incision in the petrous dura, we expose the brainstem. So we can see abducens nerve here, vertebral artery. So we can manipulate the abducens nerve and anterior inferior cerebral artery. Here is the 7th and 8th nerve. So we can touch the lower end of the pons. So we can see the basilar artery, Dolores canal. It's a little bit difficult to manipulate the basilar artery here, but we can touch it. Again, we see the lower brainstem. We can see lower cranial nerves, medulla, but we cannot work here. We can observe. And this is another cadaver, right side. Again, we see the abducens nerve here. Looks like duplicated. And we can we can manipulate the anterior inferior cerebral artery. Eighth nerve, 7th cranial nerves. Then we changed the angle of endoscope, and this is upper part, trigeminal nerve here, and superior cerebellar artery here. So this is like the real surgery I showed you. We entered the cavernous side, cavernoma from this cortical incision. So we can see the eighth cranial nerves and trigeminal nerve. So this is left side again. Final last cadaveric study I show you. This is left side, and acoustic and facial nerve here. And abducens nerve here, basilar artery, lower cranial nerves over there. We can mobilize these arteries from lower pons. And also we can see eighth, seventh cranial nerves a little bit far, but we can touch it. So lower cranial nerves are difficult to touch. So I saw two endoscopic approach, subtemporal endoscopic approach and petrous tip endoscopic approach. So this approach is good for upper brainstem, and this approach we can reach to the from the fifth, sixth, seventh, eighth cranial nerves. Looks like the entire pons lateral anterior surface we can touch it. So I think these endoscopic approaches is good for small, relatively small regions or not vascular regions. And I want to announce that we will hold the 15th Asian Oceanian International Congress on Scalpel Surgery. This become a virtual congress on demand from October 26th. And President Fernandez Miranda is one of the main guests in this congress. So please join this congress. Thank you very much.
Juan, you're muted.
I'm sorry. I was saying, Dr. Saito, thanks for your presentation and for sharing the information about the skull-based meeting in Japan, because some of the participants were asking about it. I think many of us have been waiting for this moment, this time of the day or the night, depending on where you are. So we finally have with us Dr. Goel, who is gonna share his tremendous expertise in skull-based surgery and complex skull-based lesions. I wonder if Dr. Matsushima or Dr. Kobayashi want to say a few words about Dr. Goel, who actually needs no introduction.
How about that? Dr. Kobayashi, could you give the word?
Unmute, unmute.
Mute.
Can you, Dr. Goel, can you share your screen? Try if that works. Beautiful.
Unfortunately, I didn't hear what Dr. Kobayashi said.
Dr. Kobayashi, you're up.
Dr. Kobayashi? Okay. Dr. Goel is a great skull-base surgeon. So everybody knows his name, and he has a large number of the cases. Please give us a great lecture.
Okay, thank you very much. Needless to say that it is an absolute honor and delight to be able to talk in the Rhoton Society. And Juan, I cannot pronounce your name, and there are multiple names in your name. So, Juan, what? I'm not
You're
sure.
doing it very well. Juan is good. But I like how the Japanese say Juan. It doesn't matter. It's all good.
Okay, so I'm going to talk to you on my about 37-year experience on lesions involving cavernous sinus. So it has been a long and wonderful and fantastic journey, and I'm going to summarize my thoughts over the period. And the title you can see, dural basis of surgery. So this is what Professor Rhoton called anatomical jewel box. So we have to, to enter and take the jewels, we have to work hard and we have to work dedicatedly for a long period of time in the cadaver lab and with patients. So I had an opportunity to do both these things, and that is my real pleasure and advantage. In 1996, I published this book with Professor Kobayashi and another very, sorry for that, and another legendary professor, Dr. Hongo. And this book, 1996, so 24 years ago, I summarized quite a bit of work on cavernous sinus and all those things. And majority of my part of this book was actually almost like a monograph. And there were no other references except mine in the entire part of this. This book was quite popular during those days. I cannot discuss cavernous sinus without discussing few philosophical issues, but several I have written in my publications, and the references are cited here. Speculative note, ocularizing the cavernous sinus, role in eye movement and eye health. So cavernous sinus has a role to play. Cavernous sinus is not just an anatomy lying at the base of the skull, making it all difficult for the surgeons to operate. But it has a role to play in eye movements, eye health, and several other roles, which I have mentioned in these articles of mine. Cavernous sinus with all this venous complex is very intricately related to the eyeball and the hydrodynamic system of the eyeball, hydrodynamic system of vitreous humor, aqueous humor, lens, and retrobulbar fat, and the extensive venous plexus behind the eyeball has very intense relationship with the cavernous sinus. It is mutual benefit. And I had written in my articles that without cavernous sinus, the hydrodynamic system of the cavernous sinus will not work, eye will not move, and there will be no vision. So these are very important articles, I feel, never discussed before in the literature. And this hand is like cavernous sinus holding the eyeball. These are very favorite slides of mine. I have shown at least 200 times in my various lectures over the last 35 years. And Professor Kobayashi knows about these slides, why the eyeball of a deer is located on the lateral aspect of the head, and why the eye of the lion is located right in front of the head. These are because lion is going to catch the deer, and the deer is going to run and prevent itself from being caught hold of by the lion, and also to jump and run. So the eye is located laterally. We had said that the eye moves front and behind very rapid manner, and this rapidity of manner is the cavernous sinus helps in these movements. On the other hand, lion has to just see the deer and not to bother about what is coming from behind. The range of eye movements is just 30 degrees. In humans, it is 120 degrees. So that is the bigger the eye movements, bigger the cavernous sinus. In the fish, Hakuba had said in very beautiful dissections and related to eye movements, cavernous sinus is relatively much bigger in a because it not only helps in eye movements, it also helps in the swimming and balance while swimming. So it has a special role in a fish. So beauty of the eye is of course beauty of the eye, and this is a human eye. But what lies behind the eye is also has to be very beautiful, and that is the jewel box, the cavernous sinus. And that how we have to learn to attack these jewels, I'm going to discuss in my lecture. Location of cavernous sinus by the side of pituitary gland, by the side of paranasal sinus, is indeed absolutely important. It gives information about external temperature from the paranasal sinuses, takes that information from carotid artery about body temperature, gives this information to the pituitary gland, and the pituitary gland then functions in its beauty and magnanimity and controls the entire body structure and function. So this is a very gross summary of my speculations. I will like you to read several of my articles on the subject. Now I want to give this word from Arabic legacy, which Professor Al-Mefti also liked very much. Alam al-Dimag means the meninges are the mother of brain. And also about the durability of the dura, and about the, you see, this is the dural cavity, or the whole brain is enclosed by dura, and it protects the brain. It is the most sterile compartment inside the dura. Nothing can enter into the dura, no infection from the nose, no coronavirus has ever been reported to enter into the skull cavity because of this dura. Dura is great. There is no question, and we have to really understand dura if we have to understand how to operate on various lesions involving the cavernous sinus. Over the last 35 years, there are several articles of mine on how to operate and what are the structural needs to understand when we are going to operate on cavernous sinus. In 1998, I wrote about this article and about the meningeal architecture and on various issues involving the cavernous sinus. This article also was quite popular article and well-cited article showing the relationship of the artery to the tumor. See, this artery is squeezed by the tumor, this artery is encased by the tumor, this artery is displaced by the tumor. The nature of displacement, the nature of encasement determines what is the tumor and the approach to the tumor. Before MRI was introduced in the field of neurosurgery, this information was not there, and surgery on cavernous sinus was quite primitive before MRI was introduced in the picture. So I work in a public hospital, which is a free charitable hospital right in the heart of the city of Mumbai. Because it is free and much of the population in the country cannot afford any private
Is it just me or his connection was lost?
We did lose him.
Okay.
Yeah.
That's too bad. Waiting all this long to hear him, and now, let's see, Dr. Goyle. There you go. Dr. Goyle, you are mute.
Just a minute.
There you go. Welcome back.
You can hear me?
Yes.
Okay. So there are several tumors I operated for several years. In 1995, I operated this case, small residue. There was no gamma knife. There was gamma knife, but not. Also in India, gamma knife was there, but that issue was not in question. This is another tumor in 1997. So essentially, I had the opportunity to operate all kinds of complex tumors over several years. And in 1997, I described this extradural approach to lesions involving cavernous sinus. Tumors involving intracavernous sinus. See, the Vinko Dollens, of course, the king of cavernous sinus, and described vascular lesions of cavernous sinus aneurysms and things like that. But this was the first paper in the PubMed talking about intracavernous sinus and extradural approach. So this is one tumor which is one of the most benign and one of the most difficult neurosurgical problems. I know what, I'm not sure if you will know what tumor is this, but of course in 1991, nobody knew what this tumor was, and I operated by transnasal route and extensive bleeding, and I had abandoned that operation. Then I came by lateral approach, and I published this paper, and this is publication in 1991. This was almost the first case in the literature where preoperative and postoperative imaging was shown. So this is cavernous hemangioma of cavernous sinus. This is the primary intracavernous sinus tumor. It has very characteristic radiological findings. It dilates the cavernous sinus. It goes in the intercavernous sinus towards the opposite cavernous sinus. It goes towards the orbit. It goes towards the Meckel's cave, never transgresses the dura. So it is entirely within the confines of cavernous sinus. It encases the internal carotid artery. And most important thing in this operation is to identify and save the sixth nerve. So no matter how big it becomes, it has very characteristic radiological features, like you can see towards the intercavernous sinus orbit, towards the Meckel's cave, and lateral wall of the dura is stretched outwards, but crest. So these features are absolutely critical if you have to understand and resect this tumor, absolutely vascular tumor. And I had described 13 cases in the year 2000. In the extradural approach was described for these tumors for the first time in the literature. This cavernous sinus is an extradural entity. This tumor respects the dura, and extradural approach is without question the best approach to remove these tumors. So this is one example here. Cavernous hemangioma, when to operate, when not to operate. Radiation is hardly proven to be effective. Recently, some reports, but surgery is the answer. And surgery is a difficult answer if the person is intact with eye movements. You will have to really consider. But if the patient has eye movement disturbance, then there is no question about it. I want to quickly show you some features, extradural approach to these tumors. Of course, I cannot show you the whole length of video, but extradural, this is a very, not such a clean image. Fantastic tumors to operate, but on the other hand, also difficult tumor. More important is vascularity of the tumor. Extradurally, you can expose the entire wall of the tumor. The cranial nerves, fifth, is displaced laterally by the tumor. Third nerve has its own territory, and it is separated off from the tumor. So you see now I am trying to enter the tumor above the V1. The extensive bleeding throughout the operation is the hallmark of this tumor. First thing that you have to go and identify and save the sixth nerve. That is the bottom line of this operation. And if the sixth nerve is gone, quite a bit of operation is patient will never be happy. I'm not saying you can save the sixth nerve 100% of time, but sixth nerve saving is a very important. You see, here is the sixth nerve. And then I do not like to coagulate heavily in the tumor. And you see, this is the carotid artery right in the cavernous sinus. And come with third nerve palsy, and in 3 months of surgery, the eye movements have returned. So there is a possibility to relieve the person of headache, to relieve the person of visual diplopia. There is a possibility. The thing is whether we are ready to accept this bleeding situation. And I want to quickly show you another case where a transgastrian ganglion approach was done. You see here, the gastrian ganglion is being opened to approach extradurally this tumor. And then I'm working medial to the gastrian ganglion. And you have to remember that this will bleed, and you have to remember that this will bleed quite furiously and heavily. The and clearer, and you have a very fantastic opportunity to see the entire anatomy of cavernous sinus in a panoramic vision. These tumors get supply from the infralateral trunk of the cavernous sinus, sometimes from McConnell's capsular artery. Once you get the artery, the whole thing becomes much better in your. More important is just you have to go ahead. Third nerve is away from the field. Sixth nerve is the issue, which is the major issue. Then you resect the tumor as much as possible circumferentially, and you will ultimately get a very fantastic anatomy of the whole. Like no cadaver dissection will give you this kind of anatomy once you remove the tumor from the cavernous sinus. Very fantastic anatomical exposition is possible because the whole cavernous sinus is open. The entire dural structure is opened by the tumor. So this is pre-op and this post-op. So this is one tumor which is primary intracavernous sinus. Now I want to talk to you about pituitary tumors and the relationship with dura. And there are several publications of mine on this subject, and I wish that you read these articles. So large pituitary tumors can be quite a dangerous looking tumor. You see, these are pituitary tumors. They are dangerous in the structure, but they are quite benign histologically, and you have to remove them. More important than removal is to understand them. And over the period of time, I have worked quite a bit on giant pituitary tumors. So beautiful anatomy and the relationship of dura I'm going to discuss with you. As the tumor grows, it takes the dura of the dialy up its growth. So this description was the first time in the literature. And my feeling is that this understanding that the description has completely revolutionized pituitary tumor surgery, or many of you may not know, the young people in the audience, that these tumors were removed almost 100% of time by transcranial route. But now several people operate by transnasal route. Whether you use endoscope or whether you use microscope, that is not a very important thing. More important is to understand that the diaphragm dura is going to be elevated by the tumor. And this diaphragm dura, if you know that it is not it is intracranial, but it is any artery of the circle Willis, any perforator of circle of Willis. This information is absolutely critical when you are going to operate. So this is the diaphragm celli. It is the nubbin of, still the dura is not transgressed. This nubbin is subdiaphragmatic. Even this large tumor is a nubbin, and the dura is entirely intact around this tumor. This tumor is going in the brainstem, but if you have information, if you know that there is dura around this tumor, there is a possibility that you can remove this tumor from the nose, and there is a beautiful possibility to remove this tumor from the nose. There's no need for doing transcranial operation. Bottom line is that understanding of dura has to be very clean. Grade 2 tumor I classified when the tumor goes in the cavernous sinus. Here we mention that the diaphragm of the lateral wall of the dura of cavernous sinus is never transgressed by the tumor. So these are grade 2 when the diaphragm is elevated, lateral wall is displaced. This is grade 2 when the diaphragm is elevated, lateral wall is intact, it is entirely intracavernous sinus tumor, does not transgress the dura, respects the dura. Diaphragm is intact, lateral wall is intact, diaphragm is stretched, lateral wall is stretched, but not transgressed. These are good anatomical information. 25 years ago, I described another beautiful dural relationship, that the dura of the roof of cavernous sinus is elevated by the tumor. Diaphragm. So this relationship is absolutely important if you are going to do intracavernous sinus surgery. This is not this is intracranial, but this is a dural layer is there, and this is intracavernous part of the tumor. This is subdiaphragmatic part of the tumor, and transnasal surgery is the surgery for this. You see the dural roof elevation is an absolutely important anatomical understanding that has to be there. This tumor looks quite bizarre, but you see it is roof of cavernous sinus, diaphragm celli dura, roof of cavernous sinus. So there is a method in this madness. Very rarely it transgresses the dura, and these aggressive tumor encase the artery of circle of Willis. These are not very, but quite rare forms of tumor, and these are aggressive or malignant. People who do not respect the mother dura are malignant children. Dura, diaphragm elevated, sinus, this is grade 2, elevation of dura of cavernous sinus roof, grade 3, transgression of dura, diaphragm is grade 4. So this was, I have a feeling, we described several years ago, has revolutionized the understanding of pituitary tumor, at least in my mind, and there are several, of course, publications. So giant pituitary tumors, large pituitary tumors, you can just remove the anterior wall, start debulking. Most of these tumors are soft vascular tumor, and you can debulk till the entire diaphragm dura comes down, and you can remove this tumor in good 15-20 minutes. And this, the simile of dura with the uterus. Uterus is the strongest muscle of the body. Transvaginal delivery is the best form of treatment. Abdominal surgery is not necessary. No monkey, no elephant, no animal has ever undergone transabdominal surgery. So this similarly, transnasal surgery is the most optimal route for even massive or mega pituitary tumors. And we have got several years I have been describing this dural relationship. Even when there is a subfrontal extension, this was a classical indication for cranial root, but no way, this is a beautiful post-operative. In 20 minutes, this operation is possible. You see this extension, if you know that the dura is going to be there, can be removed beautifully by transnasal. I removed this tumor 20 years ago by transnasal route, by the understanding that the dura is going to be intact. And I removed this tumor by debulking and the entire tumor in the picture. Even this tumor I removed in 1999, 21 years ago, by just removing the anterior wall of the cella, debulk the tumor, get the diaphragm, hold the diaphragm in the hand, give general traction, and you can remove the whole tumor and nothing but the tumor, which is very important. If you remove one small perforator, then you have a very difficult situation. Cavernous sinus surgery of pituitary tumor, you have to remove from the nose. You know, on very rare situation, you can come from lateral, but This dural understanding of cavernous sinus is a very important understanding. Elevation of the roof of cavernous sinus. This understanding, if you do not have this understanding, you just cannot remove this tumor by any route, whether it is transnasal or transcranial. So this, when the tumor extends along the roof of cavernous sinus, they are more aggressive forms of tumor. So this tumor I removed in 2002 by understanding that the dura is intact and remove this tumor. Very rarely it goes beyond the circle of Willis and then you have a different strategy. Now I want to go another beautiful approach tumor of mine where the dural relationships are absolutely critical. I described 73 cases in the year 2003. Now I have nearing 300 cases, which is the largest experience in the world. So in the year 2003, this article was the first article in the literature where it was mentioned that trigeminal neurinoma arises from the Gasserian ganglion. This part of the tumor is interdural in location. We had mentioned in this article that this part of the tumor is subarachnoid. So this part was between the layers of dura, and this was subarachnoid. But later, as we grew up in our understanding, we realized that large number of tumors, even this part of the tumor is interdural in location. The other beautiful thing that I described in this article for the first time in the literature as a series, that you have to improve the sensation of surgery. If you damage 30 years ago, but you can not only in the mechalscape without craniotomy, you can remove this tumor I described in 1995. So this was the tumor which we removed without opening the skull. This was another tumor which went in the posterior cranial fossa. So I removed this tumor just by dilating the foramen ovale and coming between the dura. And this is possible if you know that these tumors respect the dura. And this was another tumor which was done without opening the skull. So these tumors are located in the lateral wall of the dura, interdural in location, very critical understanding. And several of these tumors, even the posterior cranial part, is interdural in location. So if you know that these are interdural, and even if they are intracranial, subarachnoid, these tumors were removed in 2 stages till 1990, till Malice described single stage approach to these tumors. Otherwise, most of these tumors were either removed partially or were removed in 2 stages. So even in my own series in 1991, I removed this tumor in 2 stages. You can see first I removed this part and then I removed this part in 1991. In 1992, I removed this part first and this part second. You can see this postoperative. Many of these tumors are soft and necrotic. So single stage, 1 stage middle fossa approach is the most beautiful, and there is no question. Initially, in the early part of my series in 1996, we used to do a little bit extensive skull-based approaches to expose this largest trigeminal neurinomas, but as I grew personally in my experience, my exposure is not very limited. Splitting of the temporalis muscle, small craniotomy here, I go for largest tumors, very large tumors, intradural, open the lateral wall of the cavernous sinus and then debulk the tumor. Know the art of debulking, learn the art of debulking, demolishing these tumors. And many of these tumors, believe me, these are very straightforward tumors. Don't keep on coagulating within the tumor. Debulk, 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 and you will save the trigeminal nerve, and you will remove these tumors in quick time, and you will remove these tumors very effectively and very beautifully. There is no question. And as I mentioned, large number of cases, this part of the dura is intact. And I have got now nearing 300 cases of trigeminal neurinoma. And I think these are one of the most wonderful skull-based tumors to be operated. Even when there is a nubbin, you see there is a nubbin kind of thing here, but this nubbin is surrounded by dura. This understanding, believe me, and many of you know, there is no question. This is absolutely important. When the tumor extends extracranially, also surrounded by dura or perineurium, whether you want to name it dura or perineurium, but it is, and the nerves and vessels, whatever are displaced by the tumor, you can remove this tumor by reverse skull-base approach, not by nasal route. Also you can remove, but I have described in this article reverse. You come from skull and remove extracranial tumor. Quickly, I want to show you, like trigeminal neurinomas arise from the Gasserian ganglion. C2, this is C2 neurinoma, arise from the C2 ganglion. This C2 is outside the spinal canal, and it is also the anatomy of C2 is very similar to anatomy of trigeminal neurinoma. So this C2, we described the C2, it arises from the C2 ganglion. It can go inside and outside the canal like Gasserian ganglion tumor. And we have discussed two big papers. In 2008, I described that this tumor can be 1, 2, and 3. This I had described that this is subarachnoid in location. But in 2018, I described always, almost always, even this part is interdural in location. So we removed this tumor for the first time in literature long time ago without opening any part of the spinal canal, just working within the dura. Like I removed trigeminal tumor without craniotomy. So these tumors are very beautiful tumor. You open the dura lateral to the spinous process and work within the dura, and these are very beautiful tumors to operate. Similar to trigeminal neurinoma, we described that this is a third nerve tumor. Third nerve tumor arises from the oculomotor cistern inside in the interdural location. And if you know that the dura is going to be surrounding this tumor, these tumors can be very beautifully removed, and you can save the third cranial nerve. Like in this patient, this is post-operative, third nerve is saved. The tumor arises in this part of the nerve, oculomotor cistern, interdural in location. As it expands, it takes the dural wall along it. And if you have this understanding, you can, believe me, open the dura, which is not the capsule of the tumor, work within the tumor, avoid coagulation, and you can save the third nerve. This and ganglion, and it remains within the dura. And if you have this information that the entire tumor is within, anatomy is critical. If you open the dura, work within the tumor, you see cystic necrotic part of the tumor. Do not coagulate tumor too much in the region of the seventh nerve, and there is a possibility of the saving and improving the seventh nerve function. I'm not saying I have been able to ever improve the seventh nerve, but I believe there is a possibility of saving. Lower cranial nerve tumors is also interdural in location. They arise in the region of jugular bulb. So these tumors arise in the region of jugular fossa, and they take the dura Kobayashi in his article. Work within the dura, demolish the tumor without possibility, very, very big possibility of the surgery. The whole thing is within the dura, and also Sorry, Juan. So these tumors are also interdural in location, very critical. So this is the dura. I want to show you beautiful tumor of skull base and cavernous sinus relationship of clival chordomas. Clival chordomas arise from the bone, they destroy the bone and displace the soft tissue. Absolutely critical to know that the carotid artery is displaced anteriorly, cavernous sinus is displaced superiorly. Sixth nerve leaves the company of the carotid and goes along the fifth nerve here in this area. If you have this understanding of this tumor, they are extradural tumor, and I have no hesitation in saying that this article of mine published in 1995, one of the most beautiful articles on clival chordomas and chondrosarcoma, carotid artery displaced anteriorly, petrous bone destroyed. Lateral approach is the most beautiful. You can come from the nose and all those things are okay if you want to come and if you are very happy with the nasal approach. I will say nasal approach is okay, but very few cases are more suitable. Many of the cases, lateral approach is beautiful because the carotid is anterior, cavernous sinus is superior, and I described this middle fossa subgastrian ganglion approach for clival chordomas is a beautiful, relevant approach. You see this tumor, if you know that this dura is going to be intact, carotid artery is going to be anterior, you work within the dura, work within the tumor, nothing to worry about the carotid. Preserve the dome of the tumor and you will save the cranial nerves. So this is one tumor. I want to rapidly show you the video at the end of from the lateral approach. I know many of you are interested in transnasal approach, and I have to also say that clival chordoma is one tumor where it is an extradural tumor and transnasal route is good, and I will appreciate and I do myself. But transcranial route has a very fantastic advantage and is a very viable approach for several of clival chordomas, and you can control the whole story under vision. I also described supracerebellar approach for some clival chordomas. You see this going right posterior. I will not say it is, I will not come lateral. Lateral is beautiful and lateral is the best, but I want to show you one approach which I have recently described. As you can see, supracerebellar approach. From here you enter and you can have a clean shot and you can remove the whole clival chordoma, the clival chordoma right in the posterior cranial fossa, right, rather than coming from the nose, rather than coming from, you can come from transcranial and remove. More important is you can identify the sixth nerve early in the operation and preserve it and protect it, which is not possible for any transnasal route. So this is another operation. This patient had come with sixth nerve palsy, went with sixth nerve palsy, but went without the tumor. But I'm sure these tumors are difficult and dangerous and they recover very fast. Paranasal sinus tumor are different tumors. Nasopharyngeal angiofibromas are not only extradural, but they are extracranial. I had described transcranial route in 1994 for these tumors. And of course, several other people have also described, but now I think transnasal midfacial degloving or even endoscopic assisted approach is the best approach for these tumors. Epidermoid tumors are between the dura, and you have to do a beautiful interdural approach for these tumors. Aspergillomas are rare, but they are not so rare. Tuberculomas are rare. Meningiomas. You see, this is a convexity meningioma. It is not going in the superior parietal sinus. This is a benign tumor. When it goes in the superior parietal sinus, it is an aggressive tumor. When it goes in the paranasal sinus, it is nearing a malignancy. And when it goes in the paranasal sinus, it is almost like a malignant tumor. Similarly, when the tumor is outside the cavernous sinus, it is a benign tumor. When it goes inside the cavernous sinus, it is more aggressive tumor. And when it goes into the sphenoid sinus, it is nearing a malignancy. So this tumor outside the dome, outside the cavernous sinus, this is like a convexity meningioma, benign tumor. When it goes inside the cavernous sinus, it is inherently more aggressive tumor. When it goes in the sphenoid sinus, it is close to a malignant tumor. When it is entirely within the cavernous sinus, it is inherently aggressive, and you see recurrence in 6 years, and you can consider upfront radiation for these tumors only on the basis of extension. When it goes in the sphenoid sinus, you can consider only on the basis of extension upfront radiation. So this tumor is outside the cavernous sinus, attached lateral, gets in blood supply from the wall. These tumors are like convexity meningiomas. You see arising from the posterior wall of cavernous sinus like a convexity meningioma, and these are very benign in nature. So you have to change your attitude. Initially, early in my picture, I was having very extensive exposures for all kinds of tumors. For petroclival, I have described in 2004 supracerebellar approach for the first time in literature, and my feeling is fantastic, beautiful approach. You see some tumor in the cavernous sinus is remaining here. How much to remove, how much not to remove, you have to be very intelligent neurosurgeon to identify that, and you have to be perfect, absolutely perfect to know the nature of these tumors. Some information about aggressiveness can be seen by how they extend within the cavernous sinus. So over the years, I have got several meningiomas. I have got largest series in the world in tuberculum celli, largest in the world in olfactory groove meningiomas. So my understanding is curing is a non-issue in the treatment of meningioma. You do whatever you do, but you can never cure a meningioma. Basically, we have to be aggressive in our, we have to we can safely remove. We cannot say I have removed some tumor and I have removed some nerves because I wanted to cure the person. That attitude will not be valid. Recurrence, this is also a little bit controversial statement, but I believe in very strongly and aggressively this statement. Recurrence of meningioma is independent of the extent of tumor resection. So it is not the treatment, but cellular behavior that decides the outcome. So thank you very much, my dear friends. I hope you have got some messages from this lecture.
Well, that was just quite impressive and wonderful, Dr. Goel. That experience is definitely unparalleled. So we all thank you for sharing that experience with us. It's also very impressive, your expertise with all approaches, and in particular with transphenoidal approaches. I know for many years you've done spectacular work. And we have a question from the audience about how do you deal with those very large tumors that do not descend easily? Do you use any particular tricks that you're gonna share? You extend your approach? Do you use any lumbar drain? And you know, what do you use?
You know what? Pituitary tumors are very rarely firm like meningiomas. They are very rarely firm. They are soft tumors. More difficult issue is they are vascular and they bleed. They are very necrotic and cystic. They can be firm in situations with when the period of time and you are treating with drugs. In those situations, rarely they can be very firm and they do not descend no matter how much you try. But those, I will say, are very rare situations. You know the
Well, I'm sorry, guys.
Some tumor strategy of debulking, strange strategy of handling the tumor. Basically, you know, did you hear that, Juan?
No, we missed the last part. Sorry, the last 30 seconds.
Okay. So it is extremely, you know, you have to learn how to demolish the tumor. And many of these, you know, we have to learn how to break the tumor without extensive coagulation. If you see bleeding and you start coagulating, you will never be able to remove giant pituitary. You have to know when not to coagulate. When feeling is this art has to be learned with your experience and with your more and more experience. My advantage with me is I work in a hospital, which is a free public hospital, and many of my, Professor Kobayashi knows it very well. Professor Matsushima, I think he knows my hospital. It is like it is a wonderful divine heaven of neurosurgery. And that is my power. One, it is not as beautiful as Stanford Hospital, as I can see behind your back, but it is divine in its own ways.
Absolutely, and you have such an amount of patients with very complex lesions to treat that builds a unique experience. So thank you for that. Dr. Kobayashi, do you want to make any remarks? I believe you're muted because we cannot hear you. Oh, you're not muted, but we cannot hear you. Something wrong with your volume or something?
I would have loved to hear what Professor Kobayashi had to say.
Yes,
but
me too.
Unfortunately, his audio is this, he cannot.
Yes. So, Dr. Goel, are you now using the endoscope in your transfemoral approaches? Because it must be so difficult doing all those large tumors just with a microscope, no?
Professor Kobayashi is there. Let us see what he has to say on before I answer your question.
Are you up, Dr. Kobayashi?
No.
Oh.
Can you hear me now?
Yes.
Oh, thank you very much, Atul. Only one word. It's very dynamic talk, dynamic thinking, and overwhelmed. That's all. On behalf of all audience, I'd like to say thank you very much again.
Thank you, Professor Kobayashi. Your companionship over several years and your affection towards me. And you have indeed been a very solid friend, like older brother. And I wish a very happy, retirement from presidentship of Rhoton Society. And I wish you all happiness with your wonderful wife, Hideko, for several more years. And before I want to answer that question about endoscope. You see, I use endoscope for tumors which are like chordomas and all. I am not very endoscope versatile, in tell you the truth. But for no matter how big the cavernous sinus extension of pituitary tumor is, no matter how big is the intracranial extension of pituitary tumor is, I have never felt the need for any accessory instrument. I do with conventional microscopic neurosurgery, and I know how to turn my speculum and go in the suprasellar compartment. I know how to get the diaphragm down, and I have experienced now over 5,000 cases of pituitary tumors. You see, and I do not want to enter into endoscope with pituitary tumors in particular. Not, if you ask me when you would like to use endoscope, I have said I would like to use endoscope, and I would recommend endoscopic surgery for chordomas, but not for all chordomas. And transcranial surgery is a wonderful option without any doubt or without any question. You can have the protection of carotid artery right early in the operation. For chondrosarcomas, there is no question transcranial surgery is better because you cannot have any control, with these calcified tumors from the nose. Transcranial surgery is still the best option for many of these tumors. Of course, endoscope I recommend. I recommend endoscopic surgery for juvenile nasopharyngeal angiofibromas. I recommend endoscopic surgery for many of these malignancies of paranasal sinuses. But I do not recommend for any intradural tumors like tuberculum celli meningioma. I do not recommend at all. You see, dura is like a very divine membrane. I told you it protects the brain, the spiritual brain, the godly brain for all infections of the paranasal sinus. It has never allowed any coronavirus to enter into the brain. It has never allowed any zoo of animals located in the paranasal sinus to enter into the skull. Only if it is necessary or very important, you break that barrier. Otherwise, do not do for suprasellar meningioma, for olfactory group meningiomas, What do you think, Professor Kobayashi, about this? I would like to know. No, Professor Kobayashi, your voice is gone.
He wants to disappear.
But many people are now getting good experience and good hang of it. And many of these young people are my good friends and good, I have to not criticize them very heavily. But if you are asking me, I have to say, tuberculum celli meningioma is a beautiful operation transcranial. I have got the largest experience in the world. Without any doubt, I say, do a small frontal craniotomy, retract the brain, open the sylvian fissure, and demolish the tumor. It is such a beautiful tumor to be broken. Complete control of the anterior cerebral artery, complete control of the perforators, and then do removal. And these tumor, you come from the nose, you damage one perforator, the person is finished.
You know what, Pure?
Dr.
Yes.
Kobayashi? Again, we cannot hear you.
Maybe you can get Matsushima, the president, incoming president, to give a smallish comment.
Yeah.
Yeah. No comment because, your talk is so great now.
Thank you very much.
Nothing to say.
Well, it definitely will be very difficult for anybody else to build such an experience, such a large number of cases. So as they say, we stand on the shoulder of giants. So if you guys have any more comments, I will finalize the session. If you guys agree, it's been such a pleasure and an honor to have you all with us tonight. I encourage you to join us tomorrow. We have an exciting day tomorrow going ahead. And
not tomorrow, today. Not tomorrow, tonight for us.
There you go. There you go. I'm not sure when I don't even know what time is it anymore, but morning or night, whenever you are, let's say in about 10 hours, we'll have our next session, whenever you are in the world. So all of you.
Thank you very much. Thank you.
Have good rest. I will see you tomorrow.
Thank you. Thank you very much.
Thank
Bye-bye.
you. Thank you, Professor Goel. Thank you.
Thank you. Thank you.